Check. Hello. 1, 2, 3, 4. 1, 1, 2, 1. Hello. 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 One. Hello.
But it's not available to them. So it's very easy for us to kind of say, but you go there, offer yourself, and you will not be able to even handle the number of patients who probably with your assistance. So, but a lot of all this is still going on. Look at this is a kind of the number of what was the seizure control in patients that we were seeing. So you will see that while most were having at least one seizure every month, there was about 5% of our patients who were having daily seizures, which is what made such scenes on the clinic very, very frequent, that you would have patients having seizures all the time during the course of the day. And some more of what this such patients on the clinic look like. They had injuries of all kinds, which I've already shown you enough of, I think. And this is an analysis that we've done more recently, which is simply comparing injuries in patients who are getting good treatment versus patients who are mostly untreated on the lifeline. And you see that injuries is kind of reported the world over with epilepsy, but you see that you can significantly reduce injuries with effective epilepsy treatment. Whereas if patients remain untreated, then it's not difficult to understand that they are going to get very severely injured. And another thing that we have witnessed in these clinics is a lot of times patients don't really get anti-seizure medication. They get all kinds of such formulations which cost them enormous amounts of money without really giving any benefit. And unfortunately, this is not a practice not limited to the small towns and villages. In Delhi, it's very common for patients to come carrying such prescriptions, even from our large corporate hospitals, which have very celebrated neurologists. So I think it's a moment. I mean, we need to all introspect. If your patient cannot even afford, carbamazepine, which costs 200 or 300 a month, are you really justified in writing some brain tonic, which is, just like putting their money down the drain? So, in that, I think we are seriously lacking. We still continue to display no shame, no remorse. We carry on. Okay. So this was an analysis which we did, which just showed that if patients were provided non-evidence-based medicine, all you did was added to cost without any benefit to patients. This was an abstract that we had presented at the American Academy of Neurology. But, one can keep saying that, but I think till there is legislation or some law which prohibits us, we seem to have made up our minds that we will not bother. We will write whatever. So every patient will be, prescribed some nonsense, some antioxidant or something. And the poor thing doesn't know that I can stop taking this if I don't have money. I need to just continue Tegrita. They don't know that. So if they don't have money, they will stop both, your tonic as well as the anti-seizure medication. So this is the part of the training that we did. In the evenings, we would meet with whoever is the local, the local doctors, and we would kind of orient them as to how epilepsy patients that we had seen over the weekend could now be kept in follow-up. And, you might wonder, so we are looking at patients, diagnosing them, starting them on treatment, and then moving on. What about follow-up? So we did a couple of studies. This was within 6 months of starting the clinic, as to what happens to patients who are diagnosed, started on treatment, and not provided any formal follow-up. Within 6 months, well, they seem to continue taking treatment. About 50 to 60% of these patients had continued to take treatment if they were followed up within 6 months. But then the question again remained, what about the longer term? So because the clinic, as I told you, has been going on since 2009. So about 10 years later in 2019, we published this experience. One of my residents looked at outcomes on these patients who had been seen at least 5 years ago and compared those outcomes with patients who had been seen at the All India Institute in the same time. So we looked at how many of these patients had become seizure-free, how many had died, how many had prematurely stopped treatment. And the results to me are extremely encouraging, because what were we providing? Just one clinic. And if you look at outcomes in the last column at the bottom, you see that patients continuing treatment at AIMS were about 86%, on the Lifeline 70%. I think at AIMS, with all our bells and whistles, we have what all going on for the patients. In spite of that, only about 80% continue treatment. And on the Lifeline, with one solitary clinic, you can have 70% continuing treatment. I thought that was fabulous. And discontinuation of treatment at AIMS, about 5-6% had discontinued treatment, and about 20% on the Lifeline. If you look at the number that had died, about 19 had died at the All India Institute too. However, on the Lifeline, 40 had died. So of course, if you look at the proportion of resources allocated to each, you will see that even a one clinic care is very much worthwhile. If the other option is no care at all. So in 2009, this is I think one of my last few slides. In 2009, this is how it was. I would educate the patients. I would write the prescription, explain the prescription, do the doctor training in the evening. However, going forward, it was wonderful that I had so many friends join in and start chipping in so many ways. Educators, fellow neurologists coming from various parts of the country, overseas, and some of them have become regulars on the clinic now. They really look forward to coming every year. And because it's very, very rewarding when you finish your clinic and realize that you've touched so many lives. So this is the summary of the work that we've done. We have probably managed to at least spread some awareness about the disease, provide some care, provide some local training, conduct some kind of research on the ground level, and had a very unique experience even ourselves. So I think with that, yeah, so these are I think, in my opinion, some of the problems going forward. We sometimes kind of struggle to get volunteers. Our follow-up mechanisms have to be made more robust, and we also struggle to get epilepsy educators, which I think I am not even ready to do a clinic unless I have epilepsy educators, because you're just going to write a prescription and think that your job is done, and then I think you're really like kind of fooling yourself. So I thank my institute and department, and of course Impact India, that has this wonderful service going on, and all the wonderful epilepsy educators who have volunteered their time over so many years working for us. Thank you for your time and attention.
Thank you, ma'am, for sharing your wonderful work with us. जो हम लोग काम करते हैं वो बहुत ही आसान है, जो काम मैम करती है। एक जगह बैठ कर प्रैक्टिस करना, पेशेंट को केयर देना बहुत आसान है, लेकिन जो मैम का काम है दूर जाके केयर देना, ये काफी नोबल काम है और इसकी तारीफ करनी चाहिए।
I was expecting some questions. I was expecting some questions from audience. Yes, please come forward. Rishi. It is, hello.
most epilepsies are focal. 70 to 80% epilepsies are focal. And for focal epilepsies, the drug of, or the gold standard drug, even in today's time, with 12 new drugs, coming every year, remains carbamazepine. That is the gold standard. I mean, we have a very active epilepsy surgery program at the All India Institute, but unless a patient has failed carbamazepine, we will not agree to even work them up for surgery. Unless, of course, they have, an allergy to carbamazepine, they're getting a drug rash and you can't give it to them, then that's another story. But otherwise, so that's the drug that we are using for focal epilepsy on the lifeline. Sodium valproate is our go-to drug for generalized epilepsies with some concern in women. We are using it in very modest doses, 200 to 300 milligrams BD. So, and of course, along with folic acid. So those are the two main drugs that we use. Besides that, it's very limited. And these two remain very, very affordable. Phenytoin, we may occasionally use in men, not in women. The benefits are, of course, it is very inexpensive and it's only to be given once a day. So these two remain the attractive kind of, qualities, which sometimes you use it in men. And the concern is with bone health, which is there with other enzyme-inducing drugs also. But I think the use of phenytoin over the years is kind of shrinking. And at the institute, I think there are very few patients. People who are on phenytoin at this time at AIMS will probably be on 4 or 5 other drugs also. So in the context of polytherapy, one might be on phenytoin rather than in monotherapy. Injectable, no, levetiracetam, sodium valproate are also available. Only carbamazepine is not available. Benzodiazepines are available. So if you want to load the patient, for example, there are other options. And even if you have to load the patient, in an emergency with phenytoin, you need not then continue it for years. You can switch it to the other best option that would, yeah. Is that it? Thank you.
Thank you, Dr. Mamta, for clearing the query. And for the first time, probably, I don't know about the audience, we have heard about epilepsy educator. We know about diabetes educator and educators in the other field, but that is really eye-opener. Good work done. Now, the next session is again, there is a memento, customary memento to be given to the speaker. I'll request chairpersons to give a memento to Dr. Mamta. अगला टॉक फिर से दिमाग से संबंधित है and none other than Dr. Puneet Agrawal and the chairperson for the session are Dr. Ashutosh Trivedi is here, Dr. Ashutosh Trivedi, Dr. Vinod Sahu from Jhansi, and Dr. Arvind Kumar Sharma. To come to the dais, and I hand over to chairperson to take on from here. And the topic, of course, is very close to Puneet for paradigm shift in acute stroke management. What is the current scenario? Over to chairperson.
Good afternoon, everybody. Profession of Jubilee, SBI University. Now we welcome Dr. Puneet Rawal. He is Director of Neurology, Stroke and Dementia, Maxwell Studio. He is Assistant Professor in Neurology names in Delhi, Health Excellent Award, Neurology from Central Health Ministry in 2016. He presented European largest need of embolized patients of stroke in India. So and so on, because we are late. So I welcome
So, good morning, everyone. So, thanks for the introduction. Uh, First, I'd like to congratulate Dr. Richa, Dr. Saurabh, Dr. Gautam, and all their team for organizing a wonderful Silver Golden Jubilee this session here. And we really enjoyed yesterday program also. So, for going into my topic, so because I am specialized for stroke and movement disorders, did my fellowship from US in this, and then right now for last more than 15 years working as a director in neurology in Max Hospital Saket. I just tell you brief, I have 2 innings in this college. I'm really proud of that. I did my MD medicine from here from 94 to 97. And I was a star here. And I still, at the time, Dr. Chandan was HOD and later on Dr. Alam was head of department. I really proud of that. I have very fantastic, fabulous teacher here, Dr. Chandan, Dr. Santosh Kumar, Dr. Alam, Dr. Naveed Kumar, Dr. Rakesh Chandra, Dr. Arthur Chandani. I really learned a lot from them, and I'm what I am till now. I think that is because of their teaching only that I've succeeded in my practice till now. And later on, I joined as an associate professor in neurology here from 2004 to 7, and then went to fellowship and then joined Max Hospital Saket. So that is my association with this college. I'm really proud of this. And since stroke is my main forte, I have specialized in this. I'm working for last many years. I'll share my experience in a stroke program which we are running there in Max Hospital. We have very aggressive program there. We have one of the largest case of thrombolysis, more than 1,500 patients till now in last 16 years. And we have published data also. So I'd like to share my experience in this thing. So we see that stroke is second leading cause of death all over, and many times we take it very casually. When I was doing MD medicine at the time, thrombolysis was not done, was not basically not approved at the time. Since the landmark trial in 1995, the IV thrombolysis was approved all over world. In India, it came slightly late after a few years, and when I was in associate professor here, I did my IV thrombolysis. I remember I did my first IV thrombolysis here. I think that was one of the first one in UP at that time. So, so stroke now there is a long journey has passed. It has passed through a long journey from a pessimistic approach to a very aggressive approach. And nowadays we are very aggressive when a patient of brain attack or stroke comes to the triage. So brain attack is a term coined for the public purpose by WHO, and that brain attack, so that everybody is aware. Everybody is aware of heart attack, but for the brain attack or stroke, many patients they don't reach in time. Still in India, despite so much teaching, hardly 3%, less than 3% patients are getting thrombolysis in time. And window period has increased. We know that now window period of thrombolysis has increased even up to IV thrombolysis up to 4.5 hours from onset of symptoms. Then for the IV for the intra-arterial intervention, it is up to 6 hours and up to now extended to 24 hours. So we are doing intervention even up to 24 hours in selected group of patients who are having stroke. So why the time is important? Now that diagnosis of the stroke has also is changing from a symptom-based diagnosis to a tissue-based diagnosis. So if you are having a findings on imaging and which is correlated with the symptoms, then you should treat that patient as a stroke unless proven otherwise. And every second after brain attack or stroke, 32,000 neurons are dying. Every 1 minute, around 2 million neurons are dying. So that's why time is brain. We have to act fast. And we have a very active stroke alert program in Max Hospital. So whenever a patient comes to triage, the stroke or code alert is activated and goes to all the team members, which including the neurosurgeon, radiologist, even the paramedical staff who is trained for the stroke ICU, and everybody. So patient is given priorities, even for the CT scan, MRI, the patient is given priority to do the imaging immediately, and the door to needle time is maintained to the minimum. So we see here that if you do the nowadays, whenever the patient stroke comes to the trial, the CT scan is a primary modality of choice. But in confusing, doubtful cases, we can go for the MRI also, because MRI is time is time consuming. So usually CT scan is preferred if there is no doubt in the diagnosis. Patients, when there is a doubt, patients who are having wake-up strokes, in those cases, go for the MRI scan also. And this is a typical MRI. You can see here, diffusion is showing white signal, the ADC showing black, and we have a perfusion facility in our hospital. We are doing CT perfusion, MR perfusion, and we are doing intervention. Even that's why after 6 hours also, if there is a perfusion diffusion mismatch, then we go for the intervention. It is really fruitful for the patient. So earlier you treat, even if the patient comes in time within 4.5 hours, we should not wait for giving a TPA injection or tenecteplase injection. It should be, if it is given even less than 90 minutes, the chances of getting a good outcome is that 1 out of 4 person will get a good outcome. So that's why we should not wait even inside the hospital, that we still have a time of 4.5 or 6 hours and we can go slow. So that is not acceptable in patient stroke. And we have done a trial study when I was in AIMS that there is a delay in the reaching the patient to the stroke. And it has been found that most common reason in India is the traffic, that patients still knowing that they want to reach to the hospital, they're not able to reach to the suitable hospital. So patients should go to the nearby suitable hospital where CT scan facility, neurologist facility, ICU care, neurosurgeon backup is there. In that, any of the hospital patients should go to the nearby hospital and define the traffic. So which is the main constraint in Indian setting. And while coming inside the hospital also, we should try to minimize the duration of timing of giving the TPA injection or thrombolytic injection, that TPA or tenecteplase. Usually standard is should be less than 60 minutes. So patient reaching to the triage and giving the injection, this is known as door to needle time. That should be 60 minutes. In our hospital, is ranging from 22 minutes to 40 minutes in majority of the cases. So patient coming to the triage, we do the ABC assessment and then seen by neurologist immediately, which hardly takes 5 minutes to diagnose the symptoms of a stroke, and followed by IV access, blood samples taking, patient shifted to the CT scan room, and then this clot busting injection or tenecteplase or TPA is given in the CT scan room also only. So we are giving this clot, the thrombolytic drug in the CT room after diagnosis. We have to rule out the absolute contraindication, that is hemorrhage in these cases. If there is no hemorrhage, patient is fulfilling the clinical criteria of stroke and there is no other contraindication, no bleeding, patient not on anticoagulant, then patient should be thrombolized immediately. It has been seen that patients who are thrombolized without later on turn out to be not having stroke, so stroke mimickers. And it has been seen that thrombolysis does not lead to any harmful effect. And if your clinical symptoms are matching with the stroke, it's prudent to do the thrombolysis even in those cases. Now, the decision is at that time comes whether we should thrombolize these cases or not to thrombolize. So as I told you, the thrombolysis indications are that patient coming in time, that is within 6 hours of onset of symptoms, and patient is not having hemorrhage, not having any oral anticoagulation or any bleeding from anywhere. These are the major absolute contraindication. Some of the relative contraindications like having a major surgery in last 14 days are there, or having any bleed from GI tract or from urinary tract in last 3 weeks. But otherwise, there is no major contraindication. And the aspect score is very easy to do, which can be done even in any hospital by doing a CT scan and deciding whether we should thrombolyze or not. Patients who are having, so there are 10 points are there in CT scan aspect score. And if patient is having more than 7, it shows that patient will be having good outcome after thrombolysis, and we should go for that. If it is 5 to 7, the patient is a borderline case that whether we can thrombolyze but with a less good outcome, and less than 5, there is no, usually patient will be having a bad outcome. And depending on the, after discussing with the patient attendant, we can decide whether we should thrombolyze or not. Now, so as I told you that till now the TPA is the only drug which was used, but in last few years, the tenecteplase has also been approved by Indian Stroke Association. It has not been approved by FDA, but Indian Stroke Association has approved tenecteplase, which is commonly used for last more than 15-20 years for MI also, acute MI, as a alternative for TPA for thrombolysis, which can be given very in a bolus dose. It's a cheaper drug, and the advantage is a cheaper drug. It can be given in a bolus dose, while TPA requires 1 hour injection. And tenecteplase doses are 0.2 to 0.25 milligram per kg. Comes in a 20 mg vial. So I've used in many cases till now. And TPA already, you know that it's a very well tested drug for last 17 years. And it is very safe. Hardly chances of hemorrhage are hardly less than 3%. Now, what beyond 4.5 hours? So patients who are coming after 4.5 hours from the onset of symptoms, in those cases, there is a role of intervention in form of either intraarterial thrombolysis in patients who are having a major vessel blockage, or patients can undergo for the mechanical thrombectomy. So mechanical thrombectomy is done by the various devices, and these are the 5 landmark trials which have shown that it is a very good modality of treatment for patients who are having like MCA stroke, middle cerebral artery, basilar artery, or internal carotid artery strokes. In those cases, after the thrombolysis, the mechanical thrombectomy should be done unless there is a contraindication. Now, after 6 hours, till now, before 2017, the landmark trial, the DAWN trial, which has come, for last 5 years, there was the answer that we are doing the intervention to 6 hours after the onset of symptoms. But now, even after 6 hours, we have selected a group of patients who are having a mismatch. So if you're doing a MRI or CT perfusion studies, and we find that there is a mismatch between the diffusion and the NHS scoring of the patients, in those cases, we know that there is a benefit of doing an intervention versus not doing anything, versus doing only giving a ecosplit or antiplatelet drug. So in those cases, even after 6 hours, we can go for the mechanical thrombectomy. So this is a landmark trial, DAWN and DIFFUSE-C trial, which were done in 6 to 24 hours from the onset of symptoms of a stroke. And they have shown that, so like in DAWN trial, they have seen that 48.6% patients, they get better outcome as compared to 13 patients who are not getting intervention or mechanical thrombectomy, in which they use a Trevo device. And they have found in somebody that 1 in 2.8 cases have a good outcome. So results were fantastic, fabulous, that they have shown that if we include a selected group of patients, we can go for the mechanical thrombectomy. I just show you our experience in Max Hospital. So the basic concept of stroke is a teamwork. It's not a neurology. Neurologist alone will never be successful if you treat the patient of a stroke. And people have seen that patients who are treated in the stroke team or stroke unit, they have a better outcome versus patients who are treated by neurologists alone. So there are very many papers have been published on this. So in Max Hospital, Saket, we have a 8-bedded stroke ICU dedicated to stroke patients only, and we have thrombolyzed now more than 1,500 patients in last 16 years. And we have done the IV thrombolysis, we have done the mechanical thrombectomy, and I've also done sonothrombolysis. So sonothrombolysis, in which after the IV thrombolysis, we are using a transcranial Doppler And it has been seen that although it's still not FDA approved, but phase 3 trials have shown that some trials have shown that it is beneficial if we are using in patients who are having a middle cerebral artery or a anterior cerebral artery stroke, and use a transcranial Doppler which augments the role of clot busting agent or thrombolytic agents. So this is a paper published in Cerebrovascular Journal, which is the official journal of European stroke. And at that time, we formalized 390 patients. And the mean door to needle time in our center is around, so it's ranging from, as I told, 22 minutes to 55 minutes. So it should be less than 60 minutes. So many of the patients are having around 30 minutes low to middle time, means patient coming to the trial, getting a seen by neurologist, getting a CT done, CT angio done, and giving an injection. It's hardly 22 to 30 minutes, not more than that. So we are very aggressive in that context. And so the outcome is very good that this is shown in this paper. 76% patient, they have a good outcome at 3 months. We got one best paper research paper in Indian Stroke Conference in 2018, in which we have shown the predictors of outcome of patients with acute ischemic stroke in thrombolysis cases, that patients who are, so what are the predictors before thrombolysis, whether we can predict that this patient is going to perform well or not. And now we are doing extending this work, we are using a machine learning technique and AI also. We are using this data with IIT Delhi to develop an algorithm so that we can make an algorithm that we can predict beforehand that this patient will be having a good outcome and what are the probability of developing a good outcome. Now, so this one patient, see that patient 68 year with hypertension, CAD, PTCA, admitted for surgery of aortic stenosis, and during admission in cardiothoracic ward developed a stroke and double antiplatelet rubber stroke. So patient was given IV TPA, patient had a major vessel MCA stroke at the time. The TPA, there was no improvement, and then patient was subjected for DSA and mechanical thrombectomy was done. And the patient improved remarkably after 3 to 5 days. So right MCA thrombectomy was done. This is a 28-year-old male patient, known case of rheumatic heart disease, mitral stenosis, presented with sudden onset left hemiparesis after 5 hours. So patient came after window period for IV thrombolysis. So patient was basically, if you see here, the MRI diffusion was done in this case. There was a diffusion mismatch was there, diffusion perfusion mismatch was there, and patient was subjected for right MCA mechanical thrombectomy, and patient, this is a and patient improved. So patient was discharged after 7 days of this mechanical thrombectomy with a walking state with support. This is another patient having a left ICA internal carotid artery severe stenosis. You can see here, patient was having a recurrent right side hemiparesis, and the ICA was stenosed, and patient was stenting was done, and patient was attack free after that. Another patient having again, you can see here right ICA stenosis, 64-year female, had a sudden onset loss of vision in the right eye, and patient improved in 4 hours. And the patient ICA stenting was done in this case. You can see the post stenting angio that's showing that the complete decanalization. This is another interesting case, 75-year-old patient who had a wake-up stroke. So patient was seen normal in the night, and patient came to us in the morning hours at around 5:40. That it was noticed at 5:45 when he woke up, he was drowsy, speech was slurred, and patient reached to the hospital at 6:15 in the morning, and full stroke was declared, and patient was basically is out of window period in this case. You can see the MRI showing there is a infarct white signal here in the cerebellum, in the inferior cerebellar peduncle, cerebellar areas, and small part of involving pons also. So patient was basically found to be having a base. You can see the basal artery is not seen properly here in the MR angio. The DSA was done showing the top of the basal artery occlusion, and patient although came out of window period after 6 hours, but because patient was having a major vessel blockage and the perfusion study was done, there was a perfusion diffusion mismatch was significant. So patient was subjected for the mechanical thrombectomy with the PIVO device according to the Dawn trial, and patient improved NHS score to improve from 10 to 5, discharge in the walking state with support after 7 days. This is another example of delayed mechanical thrombectomy after 6 hours, that is within 24 hours. This is 41-year male. Patient had a wake-up stroke again. Stroke patient came with a left side weakness with facial palsy. NHS score was 14. And patient came late. And you can see here there was a right MCA was not seen properly. There was a right ICA stenosis also. And the patient was subjected for the right MCA thrombectomy. This 83-year female, 2 hours after onset, NHS 14 at presentation. And there was a stent, there was a ICA. So this patient was having an MCA thrombectomy was done in this case. MCA occlusion was done and MCA recanalization was done with a mechanical thrombectomy. In another case of ICA stenosis, right ICA, you can see here, the stent after stent, patient improved. Remarkably, the slurring of speech was there, recurrent slurring of speech, and patient improved after the stenting. So not only in ischemic stroke, so I like in hemorrhage also, the patients coming to us with a stroke, acute stroke having hemorrhage. There is an advancement has occurred in hemorrhage also. So patients who are having hemorrhage, the basic aim, we know that we have to control the blood pressure because initially 3 hours, there may be chances of worsening of the hematoma. And if we control the systolic blood pressure, which is most important, then we can reduce the chances of hematoma expansion and we can prevent the worsening also in majority of the cases. This is very most important thing which we should remember whenever we are treating a case of acute hemorrhage. In patients who are having a massive hemorrhage or patient having a cerebral hemorrhage, the patient was subjected for surgery, should be subjected for surgery in form of hematoma evacuation as well as a decompressive hemicraniectomy, which is life-saving also in many patients. ESA, we can diagnose certain cases of having AVM also as a cause of hemorrhage. And like in this case, having an AVM and the embolization was done in the AVM and patient was initially having the recurrent right side hemiparesis in this case, and which the attacks stopped after doing a AVM embolization. Now, even after stroke, suppose we are not patient not able to do thrombolysis, even after these, we are still very much optimistic nowadays. There is a role of intensive neuro rehab besides the pharmacotherapy. We know that there is advancement has occurred that patients are going for the patient who are having atrial fibrillation can go for the newer anticoagulation drug, Novak drug, which were not there earlier, and which also has improved the outcome in these cases with the besides not increasing chances of hemorrhage, which was there earlier with the warfarin or acetron. Now, patients, even after stroke, who are not improving in those cases, there is a role of botulinum toxin injection, and we can go for the intensive. So we have a robotic exerciser in our Max Hospital. You see here, this patient came from Dehradun, still coming to me. He came to me, I think, 2.5 years back, and he was having a right side hemiparesis. You can see here, and his right, he was walking with the toes from the right side, not able to touch the heel, having a lot of pain in the calf. The knee is bending many times while walking. He came in an incapacitated state, and I gave botulinum toxin injection in the right leg, in the hamstrings, and the calf muscles. And patient was subjected for the robotic gait trainer. And right now, patient is driving, able to drive. So even patients, I mean, he was having grade 0 power at the time of stroke. So patients, young age patient, coming with a grade 0 power on the right side, can have a good outcome. That is mean having a left side dominant hemisphere stroke, still having a good outcome if you are aggressive in terms of rehab also. So that has also scenario has also changed, and the patient is right now is independent, coming to me for last two years for the follow up. He's a patient who is driving right now. Now, this lady was having a thumb and palm deformity, having a left MCA stroke, and having a very painful right hand, closing the right hand completely, not able to do the hygiene of the right hand properly, developing pain as well as ulcers in the right hand due to that. And you can see here, she was weeping due to pain. Despite giving pharmacotherapy, it was not resolving, and physiotherapy also is not resolving. After botulinum toxin injection in the right hand, you can see the hand is completely open now. And after 2 months of functional hand exercises and the robotic hand exercises, she was able to hold the glass of water. She was able to use a mobile. So that kind of good outcome we can achieve with the aggressive rehab nowadays. I'm also having one NGO with a healing touch, so doing a health education in slum areas for last 6 years. So, so we have educated regard not so especially for the 6 non-communicable diseases like patients who are for so 6 non-communicable diseases like COPD, heart attack, cancer, as well as for the brain attack. We are doing a public education for the different areas in slum area, under poverty areas. Thank you. I'd just like to, I think one slide is remaining. So my friend and me has made a small poem. I think. It's not coming, I think we lost it. Anyway, it's not coming. So what the basic thing which I want to convey is that I really owe to all my faculty here and my teachers and this department for educating me. And I was discussing Dr. Richa earlier that if we can have a, I think Dr. Saurabh has given good idea that if we have a one account here, in which people who are volunteer to donate for the department, can be used for the academic purpose for the students. So I'm very very much ready for that. And if you can share a link on your website, so we can pay people who are interested, they can go for the donation for the which can be used for the students and for the better academics in this department. Thank you.
So much. Also, it is better.
Hello. Yeah, I think you're right. So that's what I told earlier also that hardly 10% cases getting us converted in time all over India. Like in our South anywhere, I think I suggest I say that many of the state people live, our conversion rate is hardly 7%, not more than that. So the best way to tackle it is by doing education. That's the only way. So we have to educate our patients that whenever we're treating the patient as a physician, I think as a physician we have a moral duty that we should educate our stroke patients or the family members they are having any history of stroke. So there is a term known as past FAST. It's coined by the WHO that F of phase disfigurement, acute concept and the addition of phase A for the weakness of the arm or the leg. As for the speech, then patient should reach in time to the nearby hospital. So that should be told by any physician to all the patients, if possible. Then you can run certain public awareness programs. So in we are running once a month one awareness program with the art of play, different art of play. That time big for us many years. So to art of play, we go to the art of play, come there to Max Hospital and we need to teach the importance of stroke and this stroke program to those people. That's the only way forward. I think take time. So education is key, I think. And we have no control over traffic here. So
So, window period. We should be stringent enough to put patient on RTP or and after this window period, this mechanical form of option. So is there a criteria of age for giving this ambulances?
Yeah, that's a good question. So you see that trials have included patients more than 18 years. And most of the trials earlier have included up to 80 years, but now various studies have shown that if you are mobilizing more than 80 years, unless there is some patient, because the outcome rate, the benefits are much more than having a small risk in increase in old age population. But still the outcome is very good. That's mobilized and from 97 in Baroda and sorry from Gurgaon and so she performed very well. So mobilized more than 90 years, many patients now. So age is no bar. Upper age is no bar. But pediatric population that they are not mobilized. Usually less than 18 has not come to me till now. And so up to 18 years you can formalize very well. And even more than 80 years you should formalize after explaining the risk.
So thank you, sir. Is there any for discussion?
Is there any difference in outcome of diabetic patients versus non-diabetic patients? Any data for that?
Yeah, so again, very good question. So diabetic patients are, so if you see that earlier the criteria of thrombolysis is up to 3 hours for the non-diabetic patients. Patients are having diabetes. So there is a class 3 trial, those patients are not included, fearing that the diabetes may, the uncontrolled diabetes may activate the stroke outcome. So, but now there is thrombolysis per se. There is no contraindication for thrombolysis, but sugar should be controlled. It's said that sugar should be less than, should not be less than 50 or should not be less than more than 400 for thrombolysis. If it is there, then we should correct the sugar first, and then we should go for the thrombolysis. Because so during even after thrombolysis for 24 hours, the target blood sugar is ranging should be between 140 to 180 milligrams per cent. So even less than 140, various trials have shown that outcome is not good. More than 180 outcome is not good. So strict sugar control.
Is there any data that good HbA1c control helps in recovery?
Yeah, sir. The data is there. So studies have shown that HbA1c less than 7, the diabetic patients have a good outcome at 3 months.
What are the options available?
So patients who are on single antiplatelets or double antiplatelets can and unless there is a last for that's the only content. Otherwise, you can go for thrombolysis. The only thing is you have to explain patient or double antiplatelets is a monitoring of hemorrhage, which is non-symptomatic most of the time, non-significant. That has to be explained to the patient. But the benefit. Second, patients are who are NOVAX. So that's a tricky cities. We have the patient on Devigartran coming to us. We have normalized now of Devigartran coming to us. The patient is enrolled in the stroke program from Devigartran company. Then they have a option for reaching to the drug known as Derismilumab, which is antidote. Within, so they provide free to the patients. But in that facility only in metro cities. But in other cities, patient has subjected to go for the testing of for the PT and APGT in these cases. INR has no value with the NOVAX. So you can check out the PT for the Eliquis or for the Episaban and for the Broxaban. You can check out for the AP for the Epicasa, and you can see it is normal, and patient platelet count is normal, and patient has not taken Novax 48 hours before the onset. Then you can go for thrombolysis. This is very well FDA approved. You can go in even ISS approved. So patient has Novax within 24 hours. Suppose one day before. In those cases, then you know if it is not available, then it's not Novax. That is very clear indication. And patients who are the only thing is that for the patients that are paying with the Novax. In most cases, with the antidote for the recurrent to the only methods, you can go with the APC, that is activated protein substrate, which is available everywhere nowadays, available in Kanpur also, in a dose of 20 now. It is very used in around 8 to 9 patients till now. It's very effective drug to stop the bleeding with the Novax.
Thank you, Vilas, Dr. Purit sir, for a very good presentation. My question is that we have question or maintenance of the question that you have to possibility
Then you can run cardiac arrest. By 105, that's use the anti even after normal. Sorry, not for the thrombolysis, for the non-thrombolysis, 220
blood pressure beyond which you cannot tolerate.
patients can try it. In those cases, you have to your diagnosis. So I will just so if there is low blood pressure, definitely you have to investigate the case to see whether it is really or it is really stroke. Then you first make a diagnosis. After the habit, much
The last
So, yeah, there is one question.
Right of reform. And second part of that, have you even gone through the post-thrombolytic hemorrhage?
Yeah, so patients who are the first question is that size of the stroke. So patients who are having more than 1/3 FT of MCA. So one of the nowadays that's the related contamination rate for the absolute contamination. Doing a CE, you're having a well established hypodensity and more than 1/3 FT of MCA. So that chances of having good outcome are very rare in those cases. The stroke has already has damaged the majority portion of the brain. In those cases, it is not prudent to go for the IV thrombolysis because the outcome is pay the benefit in the risk and the risk of hemorrhage, they are not so great. but definitely patients who are having a less than hypodensity, less than 1 attack, in those cases you should go for thrombolysis. Now, regarding your second question is that after post thrombolysis, the hemorrhage incidence usually is around literature, according to literature, is ranging from 1 to 3%. The fatal hemorrhage is usually less than 1%, but overall it may be up to 3% or less than 3%. So that's the usual incidence. In our series, we have seen it's hardly 2%, 1.5 to 2% in our series. So hemorrhage is not very, is not a fear, it's not fear you to go for thrombolysis. Usually, if you are selecting the patient properly, putting out the contraindications, then the chances of hemorrhage are very, very good.
So this is time to give a memento to our next speaker. Chairpersons, Dr. Richa and Dr. Gautam, to do the input. Regarding contribution to the institute, I say that there should be some income tax exemption which should be applied. And that will further motivate the people to contribute for the institute. There are many people who want to donate it and they motivated by that. Thank you, Puneet, and thank you, sir, all the chairpersons. Golden नीचे से चौक सीवी कर देते हैं. So now it is time from coming from brain to kidney. And I do remember Dr. Amit Gupta and Dr. Santosh Kumar being there. कि जब मैं इंटर्न मैंने ज्वाइन किया था मेडिसिन डिपार्टमेंट में, तो डॉक्टर अमित गुप्ता से एक बार डॉक्टर संतोष कुमार ने राउंड पे पूछा, एक मरीज जो बैठा हुआ था बेड साइड, उसके ब्लड प्रेशर इंस्ट्रूमेंट लगा के इसका बीपी रिकॉर्ड करो. And probably to what I can recollect is Dr. Amit Gupta forgot to raise the BP instrument to the heart level. And why, that is why Dr. Santosh Kumar told him कि blood pressure instrument को उठाना जरूरी है. This was a bedside BP instrument which needed to be raised. So we have learned so many things which from the institute, from our teachers, and we owe a lot. And I honestly request everybody who is present in the hall to be generous and as said by the previous speaker, to donate for the institute. Now, Dr. Amit Gupta is going to speak on saving kidney with age. We all age and we lose some of vital organs. And to chair this very important session, may I invite esteemed senior Dr. D.P. Agarwal, Dr. Deepak Nigam, and Dr. Vijay Chaudhary from Fatehpur to chair this session. कल डॉक्टर इन्होंने बताया था कि सोडियम पोटेशियम के बारे में कि पहली बार जब डॉक्टर संतोष कुमार डिपार्टमेंट में आए तो सोडियम पोटेशियम कानपुर में करवाने की शुरुआत हुई और आज हर गली हर कूचे में सोडियम पोटेशियम किया जाता है. That is the what we have learned in how we have implemented. And over to chairperson to take the proceedings for this session. Dr. Amit Gupta, please. मैं ये बात बता दूं कि डॉक्टर अमित गुप्ता रहते डबल पुलिया पे थे and his father was HOD in the orthopedics, but he never behaved like a royal, जो हम लोगों के टाइम में कहा जाता ना रॉयल ब्लड वाले. He is still that humble and he is still ready to help anybody and everyone. Dr. Amit Gupta.
Good afternoon to everybody. No introduction. He is an MBBS, and he did the MD from this prestigious institute, Kamlakar Singh Institute of Medicine. Afterward, he did the special nephrology section in NAPE, and he joined the DPI as a professor of nephrology. Then he became the head and the director of the neuroscience, the renal sciences. And he retired from there, and then he joined the Apollo Medics in Lucknow, corporate hospital. He is one of the well-known person. He is known as the Bhagwan of the nephrology. Most of the patients used to say that he is the Bhagwan of the nephrology. Now he is going to give the talk. That is very important.
सब फिजिशियन की जिंदगी में प्रैक्टिस में सबसे बड़ी दिक्कत तब आती है जब पेशेंट ट्रीट नहीं करते हैं और खास तौर से अगर किडनी थोड़ी कंट्रैक्टेड मिल जाए तो उनको लगता है कि अब तो पेशेंट को आ सकते हैं. तो हमारे एक और इम्पोर्टेंट टॉपिक है क्योंकि हमारे आदरणीय डॉक्टर अमित गुप्ता जी बोलने जा रहे हैं.
Thank you, sir, and good afternoon to all of you. After listening to two very excellent talks by the previous speakers, we now come to a mundane subject related to kidneys. But before I start, let me sort of reminisce a little bit about the time spent at this great institution and this great department. I joined, as Dr. D.P. Agarwal mentioned, because we are batchmates. We joined this college way back in 1972, so that's our 50th year as well, our golden Jubilee year, and we're going to have some celebrations of our batch later this year. I did my MD from here, and my guide was none other than Professor Santosh Kumar, who I'm really honored and privileged is part of the audience today. And if Professor Santosh Kumar remembers, in 1978, we had a patient who came from across the border and who developed acute kidney injury secondary to gastroenteritis. And he was the first patient that we did a dialysis on. And the dialysis that we did was actually a peritoneal dialysis. The catheter was inserted by none other than Professor Grewal, who was the professor of surgery. It was the first time a dialysis was being performed in the city of Kanpur as well as in this department. And I was posted with Professor Santosh Kumar as a house officer. And Dr. Krishna Agarwal, K.K. Agarwal, was the first year postgraduate. We had a 2-year MD course at that time. And both of us stayed overnight, and that the new ICU, which was opposite the new medical ward, we had this patient. And the whole night we were sort of gaining bottles, making sure that the fluid was draining out. And the two of us kept going, and in between the catheter got blocked. We took it back to the OT, where Dr. Grewal again reinserted the catheter. And fortunately for the patient, his urine out, his kidneys improved, he started making urine, and we could stop his dialysis within about 36 hours, if I remember correctly. So that was the biggest dialysis unit at this hospital, and subsequently, Professor Santosh Kumar, who had done his training in nephrology with Professor E.K.M. Smith in Canada, he started the hemodialysis unit, and he was helped by Dr. Alam and many others. And this department has grown leaps and bounds in the field of nephrology. And actually, the department has produced well over a dozen people who are practicing nephrologists all over the country. So it gives me great pleasure to be back here on this occasion of the Golden Jubilee of the department and to talk to you about something about, I changed the topic a little bit, aging and kidneys. And I dedicate this talk to Professor Santosh Kumar, my mentor, and the nephrologists who have been produced by the department, as well as to one of my batchmates who unfortunately passed away just 2 days ago. He was my caliber partner, Dr. Ajay Agarwal from Bareilly. So I dedicate this talk in his memory, and of course to Professor Santosh Kumar and to all my colleagues in nephrology. Now, what is aging? Aging, there are different definitions of aging. And one of the definitions that was provided by this gentleman Evans is that this is actually a progressive loss of functional reserve with a significant reduction in the adaptive homeostasis capacity to both external and internal stress. And as we age, therefore, there's an increase in the risk of disease as well as death. Now, with improved living conditions and socioeconomic status and healthcare, human life expectancy all over the world has increased and mortality has come down. Now, it's a fact that rapid aging has also occurred in the world population. And this human aging is associated with molecular, structural, and functional changes in various organs of our body, including the kidney. Now, during the past 2 decades, there has been an increasing interest in the aging kidney. And unfortunately, aging is very complex and is poorly understood because it involves genes, environment, and a question of chance. And it is a strong, independent contributor to mortality. And aging occurs because of cellular degeneration, which is also known as senescence, and of course, faulty repair. And its effects on the kidneys, which we'll talk a little more in detail, lead to a reduction in the GFR, an abnormality of urine concentration and dilution, and also abnormalities regarding the sodium and potassium homeostasis. Now, why is aging of kidneys a problem? Why do we need to discuss that? Because the kidney, as you're all aware, is a key organ responsible for removing metabolic waste products and extra fluid from the body. It receives almost a quarter of the cardiac output. It filters about 200 liters of blood every day and can generate 1.5 liters of waste-containing urine. And the kidneys, as we know, are highly metabolic organs, which can withstand considerable oxidative stress, but are susceptible to the aging process. And kidneys are among those organs with most prominent changes which occur during normal aging process. Now, both the glomerular filtration rate and the renal plasma flow, they start reducing after the age of 30, almost by 5 to 10% every decade. And the average yearly decline in the glomerular filtration rate in healthy individuals has been calculated to be roughly about 1 ml per minute per year per 1.73 meters square. And we all know that the rate of decline of this glomerular filtration rate would be increased because of superimposition of various diseases such as hypertension or diabetes or obstruction, etc. And after the age of 75, the rate of decline of the GFR would accelerate. But still, people have shown that it doesn't accelerate to that level that can produce kidney failure as such in the human lifespan. So if you look at this chart, which I don't know is visible to you at the back or not, it just shows you that the decline of the GFR in a healthy individual, and the decline is worsened or it accelerates, the decline of the GFR accelerates if a patient has a superimposed disease that I mentioned, like hypertension, obesity, or diabetes. And if a person has obviously developed chronic kidney disease, then the decline in the GFR is much more rapid as the age advances. Now, what happens when as the kidney gets, as we age, the kidney cortical valve volume is reduced. And this happens in parallel with the decline of the glomerular filtration rate. The number of viable glomeruli are the ones which actually are the working units with the kidney. And they would reduce almost by 7% every decade. And if you do a biopsy of these kidneys, you will see nephrosclerosis, which can be in some glomeruli, which is known as focal, or it can be in all glomeruli, which is known as global, and associated with something known as interstitial fibrosis, tubular atrophy, and arteriosclerosis. And this decline of GFR, as we said, occurs from the age of 30 onwards. And because of the decline of the GFR, there is, and the nephrosclerosis, which is occurring in some of the glomeruli, the remaining glomeruli, which are viable, which are not affected as yet, they have a compensatory hypertrophy. And the residual, there is a single nephron, a single glomerular GFR is increased in those glomeruli which are still viable. So if you look at this photograph, it shows that as we age, there's decrease in the cortical volume. There is a compensatory increase in the medullary volume. There's an increase in the surface roughness of the surface of the kidney. The sinus fat is increased, and the number of cysts, because you'll have a number of patients coming to you saying that they got an ultrasound done for something and they've noticed a cyst. So, Doctor, what is this problem? Now, cysts develop in any individual after the age of 40. So, you can have cysts developing, and these cysts, if they don't contain anything, they're known as simple cysts. But if you have something inside those cysts, then they're known as complex. So if you have simple cysts, then nothing is to be done. Only thing that you reassure your patient that this is part of the aging, and that he should repeat an ultrasound once a year at least, and to make sure that there's nothing accumulating within those cysts. If there is something accumulating, then obviously that needs to be investigated to see if there's any malignancy developing it out. So the cortical volume loss is there, as I mentioned, and the findings are these findings are underlying nephrosis, loss of nephrons, hypertrophy of the remaining tubules, and tubular diabetic valve. And this is just a photomicrograph, a representative of if you do a biopsy, like I mentioned earlier, that it shows ischemic changes, increase in Byzantine matrix, etc. So what are functional and structural changes? You can have clinical changes, both microscopic and macroscopic changes. And as a result of this, you can have functional changes. Clinical changes, I mentioned there could be a drop in GFR, there could be the reduction in the functional reserve of the kidney. And you see the microscopic changes can happen in the form of glomerular sclerosis, interstitial fibrosis. The macroscopic changes, that could be the loss of weight, reduction of the weight, the loss of mass, the length of the kidney is reduced, and the parenchyma is reduced. These are the changes that can develop because of the aging process itself. Now, because of the progressive tubular dysfunction, there is abnormalities you can see of the electrolytes. So there's reduced reabsorption of sodium, reduced ability of the kidneys to excrete the potassium, reduced urinary concentrating capacity, and these can increase the susceptibility of these organs to develop something known as acute kidney injury. The elderly patients also show a reduction in the transtubular potassium gradients, and they fail to increase the distal potassium, tubular potassium excretion, which, if you remember from your physiology days, is important. Because if that does not happen, the patient can become hyperkalemic. There are vascular changes which can increase your renal sympathetic tone, increase vasoconstriction, and the renal vasodilators, like the AN, the nitric oxide, the amino acids, they become less effective as we get older. So in general, the electrolyte and fluid homeostasis is relatively well maintained during normal age. In a steady state condition, older individuals can maintain a balanced sodium levels. But remember, under stressful conditions, the ability to maximally dilute the urine is impaired and the excreted water load is compromised. Secondly, aging kidneys, as I mentioned earlier, there is a significant impairment in the reduction of the urinary sodium excretion in response to a deprivation or reduction of the sodium chloride intake. So when we take less salt, our normal response of the kidneys is to reduce the amount of sodium lost to the urine. But that does not happen in the elderly patients. And as I mentioned earlier, potassium handling is negatively handled by aging. And therefore, older individuals are susceptible to developing hyperkalemia when using certain drugs such as RAS inhibitors, etc. So we have to be careful in these patients. So this is again another slide which just shows you the age-related pathways which contribute to altered renal outcomes in their disease. You can have various like the vascular responses or the profibrotic response to the inflammation or the increases in senescence and oxidative damage, which can lead to structural changes, tubular dysfunction, loss of GFR, etc. Now, a word about this signaling pathway, because this is something new, which is that they're talking about the falling Klotho levels. Klotho is an enzyme which is increased by the kidneys, and this Klotho and FGF23 are present in the human kidneys. And as we become older, the Klotho levels decline with age and implicated in accelerated age-related chronic kidney disease and ankylosing sclerosis. And the patients with increased functional Klotho expression, they have the lifespan is longer. So as your Klotho levels fall, the FGF23 will go up, and this would alter your phosphorus and calcium homeostasis. And clinical studies have shown that in patients on dialysis and with chronic kidney disease have higher FGF23 levels, which are associated with increased mortality. So as we get older, our Klotho levels drop, FGF23 goes up, and this can affect the calcium phosphorus homeostasis. This is associated with our lifespan or increases the mortality level. Now, what is the clinical significance of the aging kidney? As we need to be careful about the dosage of the drugs that we administer to our patients, particularly water-soluble medications, which are clear to the kidney. There needs to be an increased caution about the use of non-steroidal anti-inflammatory drugs and contrast agents. Age-related nephrostosis makes these patients more vulnerable and susceptible to develop acute kidney injury and with initial presentation of chronic kidney disease. But the other part is that the age-related kidney function decline has very little effect on life expectancy. So people have suggested that even though you have elderly individuals who are actually healthy, on investigations, you should not exclude them as potential kidney donors. Because we have this problem when you need to go in for a kidney transplant, you may have a family member who's about 70 years of age or above 70. And then you have this dilemma, should we accept a kidney from such an individual for the patient? So the literature now suggests that if the individual is healthy, if his renal functions are absolutely normal, there's no problem with his cardiac status, he can undergo surgery, then such an individual can be accepted as a donor. Because even if he stays with one kidney, it is not really going to affect his ultimate lifespan because of removal of one kidney. Now, what is the relevance of aging-associated changes in GFR for the diagnosis of chronic kidney disease and the assessment of the risk of adverse events? Now, KDIGO, which is an international kidney body or nephrology body, which gives various guidelines for the management of various problems. A decade ago gave the definition, how do you sort of diagnose chronic kidney disease? So they said that any individual who is GFR, they were the first in 2012 to start this concept of GFR. You must assess the GFR. The GFR, anything less than 60 ml per minute per 1.73 meters square for more than 3 months, irrespective of the age, is usually considered to be a patient with chronic kidney disease. Now, if you have such a definition, it is considered that then there would be an overdiagnosis of chronic kidney disease in the healthy adults. Because as we have told you earlier, the GFR declines as age advances. So adults above the age of 70, almost half of them, by this definition, would be considered to have chronic kidney disease. So this is just a schematic diagram where they have looked at the GFR levels and they have looked at the albuminuria levels, that is loss of albumin in the urine, to ascertain the risk, the development of chronic kidney disease and the adverse events that may happen. And they have showed that elderly individuals who have a GFR of between 45 to 59 may not be as much of a risk as, say, somebody who is less than 65 years of age. So there are some publications of late which are suggesting that the KDIGO or the definition for chronic kidney disease is actually less than 60 ml. But we may need to alter it in elderly individuals above the age of 65 and suggest that those who have less than 45 ml of GFR should be considered to have chronic kidney disease, because the reduction of the GFR is a natural aging process which occurs in the elderly individuals. So if we look at the KDIGO, the prevalence of chronic kidney disease is roughly 13% in the US population. And in the age, as I told you, that above the age of 70 years, almost half of them will be considered to have chronic kidney disease. And therefore, people are now suggesting that we need to relook at it, because they said that in the elderly population, there is not so much significant drop and not so much of proteinuria or albuminuria that happens, but it's basically the drop in GFR. And drop in GFR alone may not be the only criteria for diagnosing them to have chronic kidney disease. AKI, as I mentioned, that if there is increased susceptibility to AKI, nephrotoxic AKI or ischemic reperfusion, and we must remember that there is a diminished potential for recovery in the elderly people. And in a paper way back in 2018 that they showed that the prevalence advances as age progresses. It's about 26% between the age of 66 to 69 years. It goes up to 110 if the individual is more than 85 years per 100,000 patient years. Again, diabetic nephropathy is more common in elderly individuals. Certain glomerular diseases are more common in elderly individuals, like membranous nephropathy. Now we finally come to what are the various therapeutic strategies that are available to us to counteract this renal aging. And the most important they have found is calorie restriction. The beneficial effect of calorie restriction was first described almost 80 years ago. And initially, and most of the data has come from animal experiments, that the lifespan was prolonged in rats who were subjected to lifelong calorie restriction. And this finding has been corroborated by other studies in a variety of species, including non-human primates. The age-related changes in the kidney can be modulated by this calorie restriction. And they have shown that if you reduce the calorie in these animals, the age-associated structural and functional changes in the kidney can be mitigated, and animals resistant to diverse experimental kidney injuries. And this paper in 2002 actually showed that in humans, there could be beneficial effects of short-term calorie restrictions have been demonstrated, that drop in blood pressure, a reduction in body weight, reduction in cholesterol, a reduction in the blood glucose, which can lead to attenuated atherosclerosis, and a reduction in urine nitrogen and creatinine and uric acid. But the biggest challenge that we have, that a lifelong calorie restriction is not feasible in human beings. Even though we have demonstrated that in animals this has of great benefit, but in human beings, how do we insist and sort of make sure that they will reduce their calorie intake for the entire life? So that is a challenge for us, but there is definite evidence to suggest that if you reduce your intake of calories, you may be able to slow the aging process. And numerous molecules mediate the beneficial effects of calorie restriction. And one of them is sirtuin-1, which has been shown to sort of is important in calorie-mediated signaling process. The second thing is RAS block. Now, some studies have shown that the blockade of RAS could alleviate the cardiovascular aging, could reduce the renal senescence in hypertension in rats, and improve the mitochondrial number and function. And ARBs have been shown to extend the lifespan in both mice and hypertensive rats. And long-term treatment with ACE inhibitors such as enalapril has prolonged the lifespan in longotensive adult Wistar rats fed with hyperlipidemia. So it's tempting to speculate that ACE inhibitors and ARBs may possess an anti-aging effect on the kidneys in humans, but we need more data to confirm this. Then there are certain anti-diabetic molecules that people are looking at. One of them is pioglitazone, which is a proliferator activated receptor gamma agonist. And in one of these publications, it was shown that this alleviates the age-related renal changes. It reduces proteinuria, sclerosis, cell senescence, and drop in GFR. And the underlying mechanisms may include various molecular methods like the mitochondrial protection, the activation of these proliferator activated receptors, and associated with increased growth that we talked about, and reduced protein kinase. SGLT2 inhibitors is another agent that people are looking at, which may improve the renal or reduce the renal aging process. Metformin is another antidiabetic molecule that people are looking at, because in vivo, it's been shown to protect kidneys from diabetes, can induce hypertrophy, and also prevents cisplatin and gentamicin-induced renal injury in mice. So it's promising, but that metformin may be used safely in healthy individuals to prevent aging and possibly age-related renal changes. Rapamycin is another drug which we use in patients who have received a transplant. This is an inhibitor of mTOR, and this prevents cell senescence following the activation of this mTOR pathway and can delay the premature aging. The problem is that there are several side effects with rapamycin. There can be infections because of use of that drug. There may be dermatological adverse events. There can be metabolic changes, such as hyperlipidemia, increased insulin, know that. So this may not be a likely optimal choice for the prevention of renal aging in healthy individuals. Another very interesting thing that people are looking at, ablation of the senescent cells, where naturally occurring these P16 positive cells in transgenic mice. They could be, if you can ablate them, they could attenuate age-related pathological changes in the kidney. And so people are developing certain drugs, which are known as senolytic drugs, which can target the senescent cell apoptosis, but does not affect the non-senescent cells. And that is navitoclax, dasatinib, and quercetin. So these are certain drugs which are which people are looking at, and there are certain trials which are going on. So, but actually, there's still not much is known about the effect of these drugs in actual aging. And this is obviously a promising area. Then you have anti-fibrosis therapy that people are looking at, particularly the TGF-beta pathway. So this is just to show you that various processes affect the kidney as we get older. And these are certain pathways that people are looking at for potential treatment or to slow down the progression of disease. So in conclusion, ladies and gentlemen, normal healthy aging of the kidney is characterized by progressively increasing nephrosclerosis with loss of functional glomeruli and reduced function. The decline in the kidney cortical volume from this nephrosclerosis is compensated partly by nephron hypertrophy of the remaining nephrons, which is mostly the medulla. The age 50 years of compensation is less adequate and total kidney volume declines. Fixed GFR thresholds for the diagnosis of chronic kidney disease may not be reasonable because they fail to account for the decline of the GFR with normal aging. And there is some suggestion that lower GFR reference to define chronic kidney disease in the elderly may be required, say less than 45 ml per minute for 1.73 liters. And the therapeutic options, unfortunately, we do not have any good therapeutic option at the moment. But people are looking at number of interventions with the hope that someday we'll be able to achieve the slowing of the kidney aging. But we definitely need more work in this field. Thank you once again, and I thank the organizers for having me here on this occasion of the Golden Jubilee. It's indeed a great privilege for me to have spoken before this crowd. Thank you so much.
Thank you, Dr. Amit sir.
There will be some questions.
Yes.
Yes.
The teacher and the disciple, both of them are here with the government seat. I love to see that disciple get and I can mutilate both of you that you are together. My question is really a recent one. In the time of this COVID-19, lot of teleconsultations are being done. And patient reports their blood pressure on them. And almost 99% patients take their blood pressure in an electronic machine. So my question is that the rule of keeping the blood pressure instrument in the of 1 hour, how does it hold good in case of electronic instrument?
Difficult.
I think I could blame you for raising this.
Professor Santosh Kumar is sitting there.
I think everyone would agree that lot of teleconsultations are going on these days.
Yeah.
And patient reports himself or herself.
And we have to write a prescription on a software, or we make a photograph of the prescription and we send it to the patient.
So actually the point regarding keeping the blood pressure at the level of the heart is still very valid, irrespective of the instrument that we are using, whether it's mercury or electronic, because there would be a difference of at least a few millimeters, of about 5 or so. And Anil can sort of correct me because he deals with this more often than I do. So I think I would still suggest and recommend that what I learned from Professor Santosh Kumar when he corrected me that you should take the blood pressure and try and keep the instrument at the level of the heart still holds true.
Yes, sir. You.
Dr. Trivedi, would you like to say something?
Sir, delighted to see you again. Thank you for that. We have delivered so many, more than thousands of talks in GPGR, and we have learned a lot from you. I must congratulate you to bring upon highlight about the logo. We have talked a lot about this logo. For all youngsters, my question to you is how we can increase the logo in our system, in our body, because globally, it is going to be the aging process overall as well as the aging process of the people. So what are the natural sources of logo?
Well, I don't know. I mean, what are the natural sources of chloro? But essentially, if you protect your kidneys, that would help in preventing the reduction of your chloro levels. So I will not be able to answer your question as to what are the natural sources of chloro. If you are aware, maybe you can tell us.
Yes, sir.
Yeah, I think that.
Yes.
And later on, Professor D.K. Srivastav joined the Department of
Yes,
Medicine. And then
There
he
is
started.
still a room and
he started doing
lab, biochemistry lab.
and he started doing the electrolytes. We didn't have access to electrolytes at that point of time. Yeah.
MRI, non-steroidal MRI.
See, the role of MRA, particularly the newer one called finerenone, which has just come into the market, has now been sort of said to slow the progression of the kidney disease, particularly in diabetics. But whether it will slow the or delay the aging of the kidney is yet to be asserted. That is not yet. Actually, what is recommended that any patient who has developed a EGFR of less than 30 should be referred straight away to the nephrologist. Anything less than 30 ml per minute of EGFR. But people now, there's considerable awareness amongst the general public. So they are also coming to the nephrologist even with lower creatinines, where the EGFR is above 30, maybe the range of 40, 45.
Yes, sir.
Anil and I, he was the intern and house officer when I was the house officer in residence. So,
digital one. Number of times you tried also. Patient of the patient should be same, and let's say, lying down. Height at the level of heart is not necessary.
That reminds me when we were, Professor Ram Singh, you mentioned about that you were working. The Professor Ram Singh was the head of department of medicine when I joined the house job, and I was his house officer. And Professor Ram Singh's son, of course, was my batchmate, Sanjay, Devi, if you remember. But the thing about Professor Ram Singh was very strict, and everyone was literally scared of him. And there was this thing that if he's sitting in his office, even if the room is closed, don't walk in front of his office. You can go the other way around. So, because just in case Dr. Ram Singh comes out of the room and he may ask you, what are you doing loitering in this place? So we were all literally scared. Those were the days, actually. Aarti was also one of our, had worked with our unit at the time.
Yes. Yes, these were all the three here, Dr. Anil Gupta and Dr. Jubilee, and I was the next para. And what used to happen was he and some of his seniors, Dr. S.K. Podat, they all had girlfriends, so they all used to go away, and we used to be there. Dr. Anil Trivedi didn't have a girlfriend, I didn't have a boyfriend, and Dr. Anil Gupta had a girlfriend, but he never used to go. But what used to happen was Dr. Ajay Kure was there. He had a girlfriend, go up with Anurita, no, Ravi Sari, go with Anurita, saying, Ajay Sankar, Ajay Sankar used to go with Lata.
Ravi's sister.
Ravi's sister, Sari.
Ravi's sister.
Yes.
Shalini.
Used to go. Podar used to go with my dad, Vimla Podar. S.K. Podar used to go away. So we were the two people there. And then when I had a boyfriend, and Dr. Anil Trivedi never used to let me go. He used to say, 11 बजे तक काम करो, private 50 round में सारे procedure करो. अगर इतनी पढ़ी है तो वो लेने आएगा तुमको यहीं पे.
One question regarding caloric restriction. There is lot of support in Indian mythology for fasting, time restricted eating. Any comment on that regarding aging and kidney?
I mean, there is calorie restriction. If it's not only one time or for a few days, it's calorie restriction for a prolonged period of time. So it's not that you fast one day in a week is going to have enormous impact. But yes, you should try and reduce your calorie intake by and large on the whole.
Yes.
I'm Dr. Sushil Suri from Parazet. Thank you very much. And thanks, John. Thanks for the rest of my I'm on my seat. I must be the most scared. But still, I have to say something. That one question regarding one of the patient which I am really use for it. Please do so. How long that can be? This some
Often you can use, but only remember that this can have some adverse effect on the liver functions. So you need to monitor the liver functions. Secondly, one should avoid using tolvaptan if you have renal insufficiency. So if you have somebody whose creatinine is in excess of say 2.5 or 3, I would avoid using tolvaptan. So those are, but I do not know is there any time length as to how long can you use it. We generally, I think I've used for at the most 2 weeks or a month at a stretch. Beyond that, I have not used for prediction of hyponatremia. But in tolvaptan, we use in patients with autosomal dominant polycystic kidney disease, because it is shown that in studies that in these patients, ADPKD, tolvaptan helps in slowing the development or the increase in the cyst size. So that is one group of patients where we use tolvaptan for a prolonged period of time. But again, if you have a patient whose creatinine has gone up, then you need to sort of stop the tolvaptan. And again, you must make sure that not dehydrated. If you're using it in patients.
Age is more than 70 years of age. I'm working out. I prescribed and talk about the patients. Because he was a little drowsy and I did a certain test on that. And it was close by. Then he went back to home. And the gentleman kept on using the because after stopping the he was find that he's getting close. He came to me after 2 years. And he was doing daily. And his low function were all normal. I don't know what to do with this.
He's got a retreat.
So I have this question.
I think we need to look up the literature. We couldn't find anything.
I don't know. Number two. There are now comments. Although I'm interested. The hypertension measurements. What is more important than the heart level is that the patient must be relaxed and the physician have not smoked half an hour before, has not taken any caffeine or tea half an hour before. That kind of a patient has to be maintained for measuring the proper practice. And always remember to provide for hypertension. So all these 3-5 things are more important.
Absolutely. I think I'm really happy that you brought this out. I actually tell all my patients that you must record your blood pressure at home, because home environment is the best environment where the patient is relaxed. White coat hypertension is a major reality. So there, and at home also, you take an average of 3 blood pressure recordings. So what is recommended is that you take the blood pressure 3 times, I would say a minute or 2 minutes interval, and take the average of that. And it should be done at home. And that is what we should base our antihypertensive therapy on. This is a new area that people are looking at, because they are trying to presume that if we can ablate those cells which have died, then the cells which are still alive may have a greater chance of, there'll be fewer cells which may be getting senilized subsequently. So that is what the theory is. They are trying experimental animals as yet. No human trials have been done as yet. And so they're thinking of, if you can ablate these cells which are senilized, perhaps you can increase the lifespan.
Director session. House is very much benefited definitely, and we are comments. हम लोग बहुत ही fortunate हैं that you are between us. Thank you, sir. Thank you very much.
Thank you indeed.
So trying to give memento to the speaker, please, Dr. Richa and Dr. Gautam, to give it the chairpersons to give memento to Dr. Amit Gupta. So with that, we move on to last session of the day. And this is to be delivered by none other than Dr. Navneet Kumar, who is the alumni of again this institute and has been principal. Topic is epilepsy, new drugs. And to chair this session, I like to invite Dr. P.C. Singh sir, Dr. D.K. Sinha sir, Dr. Umesh Prajapati from Devariya. So, over to chairpersons to take over session from here. Dr. P.C. Singh, Dr. D.K. Sinha, and Umesh Prajapati.
To pay tribute to the past of it, क्योंकि I was the earliest person. अभी नहीं, later.
Yes, I take pleasure in inviting Dr. Professor, Principal, ex-principal of this college and alumni, Dr. Navneet Kumar, to the dais. And as all of you know, that he has been principal of this medical college from 2012 to 2018. Founder of Neurology and Neurosurgery Department and established a dedicated neuroscience center at the Medical College. Publications and has written books on neurology, textbook of neurology, and book of neurology examination, easy back causes, diagnosis, and cure. Lifetime achievement award. Actively practicing clinical neurology that established Bhushan Health Foundation towards support. So the subject is epilepsy, and he's going to talk about newer drugs in epilepsy.
I begin. Thank you very much, Dr. P.C. Singh sir, for the nice words for me. I had visited this department in 1984 when I was doing my MD medicine at KGMC. Dr. Sikka was organizer of a state level medicine update here. And I never knew that I will ever be here as a faculty after 4 or 5 years. And then will become head of department for some time, obviously against my wish that was. And then I became principal of this college and worked for 6 years and few months. So I have 12 years of my working in KGMC during when I did my MBBS, MDDM and chief residency, but I spent 30 years in this college during my prime life. I never expected that Richa will organize this program in such a mammoth way, such a fantastic show with her teammates, with the group. But it was really a memory to live with for some time. I could not come back last night because I was in Banaras in a neurology update. I returned midnight. So I was not able to attend the dinner function yesterday. Now, epilepsy is one subject which all of us treat. All of us see the patients of seizures, and we treat these epilepsy patients in 4 steps. The step 1 basically is a step to make sure patient has a seizure or doesn't have a seizure. In the step 2, we investigate the patient. In the step 3, we try to come to a syndromic diagnosis of the patient, and then we pick up the right drug for the patient's suitability. What happens is that despite the fact the patient has a very different kinds of presentations, but even today, 10% patients of epilepsy clinics world over are those patients who probably do not have epilepsy, and they are giving treatment for epilepsy. And similarly, certain patients who do not have who have epilepsy are thought to be a patient of psychogenic seizures. So what are we left with? Basically, we are left with only to find out like a detailed history of the patient of the seizure, whether how the seizure occurred. And there are so many fallacies in that history elicitation that even the best experts probably will fail. So who will succeed? A physician who has a history of the patient, how it happened, what time it happened, for how long it happened, any feature of tongue-bite or incontinence or not, and so on. So the history, I think, is very important. And when I was a faculty in the department here for 27 years, for 23 years, before I went to become principal of this college, I always said, it is better to be a good physician than to be a bad neurologist. Because despite you may have a DM or something like that, you will not diagnose properly, don't take history properly, then there's no point being a neurologist as such. But a physician, I think, will be a better neurologist if he has taken time in the patient diagnosis. When I came to this college in 1989, I was given full support by so many colleagues and so many doctors from the town. They gave me support, and I obviously established myself in a new city, new environment. Now remember the importance of good physician. I take the name of a physician who would refer patients to me for neurology. And I take the name of the doctor who is here, Dr. D.P. Agarwal sir. He happened to refer me a patient, and he wrote down suspected periodic paralysis. The patient had body paralysis twice, recovered, and I was really surprised that a physician in 1959 was able to diagnose this condition and refer the case to me. I worked on the patient, and patient was having hypocalcemia. He was right at that time. Then I realized, I told all my students, be a good physician first, diagnose neurological patients, then making error. So that error actually is done by most of us in epilepsy management. And once we have taken the history of the patient of epilepsy and we have taken all kinds of investigations, then we try to fit the case into an epilepsy syndrome. And that is the main reason that we are able to get to the correct choice of the drug by doing this homework of identifying a syndromic diagnosis in epilepsy. And then obviously we come to the step 4, the drug of choice we pick up. The topic basically is a newer drugs. But I think before I go further, I must tell you, Dr. Mamta had spoken in the morning here is that in epilepsy management, the conventional drugs, even today, are the basic treatment strength for all of us, rather jumping out to the newer drugs. I just tell you in short about these 6 drugs, which are basically older drugs, but we can't dispense without them. We use them even today. Gardiner, the drug which obviously is a broad spectrum anti-seizure drug, had few problems of joint pains, arthralgias, impotence, and vitamin K deficiency. But the drug has been the #1 drug world over till recently, because all patients of any epilepsy you treat with this drug will be managed or treated or cured. The second drug, phenytoin, which we all use again today, even we are using, our surgeons using it for short-term therapy, had only 3 or 4 major drawbacks: gum hyperplasia, ataxia, facial coarsening of hairs, impotence, neuropathy, and it can't be given in pregnancy. Otherwise, this drug, a single dose therapy, so easy to take, has been the #1 drug in Europe till 5 years before. Despite the fact that we have dramatic advances in the management, in the armamentarium of newer drugs, still this drug was #1 drug in Europe till 5 years before. The third drug, carbamazepine, as you have been told today morning, that 70% of epilepsy patients are basically having focal seizures. Either we see them or we look at the diagnosis by the CT or by the EEG findings, they are focal seizures. And even today, the drug of choice all over the world is carbamazepine as a first-line monotherapy for partial seizures. And if they can't take it due to certain reasons, due to rash and all that, then they will use also carbamazepine in case of that. That is really costlier than that. Look at the side effects. Very few. And one important side effect of this drug is hyponatremia, which often is missed by some of us. And the fourth drug again is a broad spectrum anti-seizure drug, which is also GABA agonist and also a sodium channel blocker. This drug, valproate, has got 4 important issues which nobody wants to accept: weight gain, hair loss, tremors, and menstrual problems are the important side toxicity of this drug. Because of that, this drug has got limitations. But till 10 years before the advent of newer drugs like levetiracetam, this was the drug of choice amongst the medicos also for their self-use. It was a very effective, powerful drug as an anti-seizure drug. This is a drug obviously which can take it in place of carbamazepine. So obviously I won't talk about this much. The next just an issue, I'll show you this video of a patient. I've already shown this video. Next one. So then why do we need the newer drugs? The question is this: when they are so effective, they're broad spectrum, they have certain side issues, but why do we need newer drugs? The reason we need the newer drugs is that newer drugs, which I'll talk about in short, are having lesser side effects. Mainly because they have a very lesser protein binding, 50%, 20% at max. Other drugs had a high protein binding of 75%, 80%, 90%, and because of that, there were a lot of drug interactions. And that is why the main reason was the fewer side effects. And apart from that, 2 drugs at present are already safe in pregnancy, and these drugs are lamotrigine and levetiracetam. So lev and lamotrigine are 2 drugs which are absolutely safe rather in pregnancy or in childbearing age in females, and not other ones. If carbamazepine has got a level 2 evidence of safety, otherwise it's not safe to give to the patients. And the next reason of newer drugs invention has been the drugs for orphan syndrome. What is orphan syndrome? A condition which doesn't have any treatment. Like Dravet syndrome, a specific drug has been brought up, that is cannabidiol. And for tuberous sclerosis, a specific drug has been brought up, that is a fenfluramine. So this is the 4 indications for which the newer drugs have found some use in our clinical practice. The master chart of all the drugs which we have today, the newer drugs, And I will just tell you about the last four, in fact, little more about them, which we are using out of, obviously, we have to, last one is not really big here. Three we are using for patients or epilepsy. Now, what is happening is that we have three categories of drugs. The first is conventional drugs, which I told you earlier, phenobarbital, carbamazepine, phenytoin, and valproate, and muscarinic, conventional drugs. And then there are drugs which were basically, in between, like topiramate and lamotrigine, which came in between. So among the newer drugs, let me tell you about four drugs which are used basically in children. Felbamate, no more new drug now, it was invented 20 years before, but it has been still used in some patients. In those patients of LG syndrome where nothing works, then we add this drug. Nothing works, then we add this drug. As simple as that. But this drug is known to cause two effects, important effects, aplastic anemia, and second is hepatic dysfunction. Therefore, it is withdrawn from general use. Rufinamide obviously was also launched 15 years before, used sometime in those patients who are not responding to refractory LG syndrome. Cannabidiol. Now, this is a plant of marijuana, which grows at the roadside. If you go on the road, you will find on both sides this plant is growing out, and this is a plant which is the main source of the intoxication which people take, marijuana. But this particular plant has given a new molecule that is tetrahydrocannabidiol, which is not having any side effect like the one with the original molecule had. So therefore, this drug has been found, invented for the management of Lennox-Gastaut syndrome just 2 years before. It is a very costly drug, not available in our country, so therefore I will not talk about much in detail about it. The fourth drug in children basically was a drug which was phenpramine. Aldrex, drug was used by physicians, maybe to use this drug for weight reduction, for obesity management. It is also banned at present, not available here. So this drug is also known to cause valvular heart disease in certain patients. So it is to be used very carefully. So these four drugs, lamotrigine, topiramate, denosumab, and levetiracetam, these four drugs are not very new drugs. They are now at least 7 to 10 or 8 years old drugs, 10 years old drug. But lamotrigine is one drug which has found newer indications day by day. And today, lamotrigine is a one drug which is the safest drug for partial seizures also, and also for generalized seizures, also for Lennox-Gastaut syndrome, and for monotherapy in patients overall, all of them, and also used as a generalized as add-on therapy in refractory seizures. If you ask me, I don't use it because this drug is known to cause skin reactions. And two of my patients, when I was a faculty in this college, two of my patients nearly died. The mistake was mine because it requires slow titration. It takes 2 months to give the full dose in the patients. That is why if you give it the small dose in the beginning for 2 months to build up the regular doses, then drug is absolutely safe. But in the beginning only, you give it in a higher dose, in a full dose, patient will certainly develop skin reactions. Topiramate came with great fanfare. Unfortunately, confined to the migraine management. This drug is known to cause very important side effect. That is a very important, interesting side effect. That is a tingling and pin sensation in the body. Patient is given 50 milligram of topiramate. Patient will come back to you and says, I have developed, paresthesia in my body. So obviously, you can't go beyond that. That is why this drug, although the drug had two important functions, GABA agonist and inhibition of sodium channel block. That was the reason. But this also, faded in amongst so many other drugs. Denosumab is a Japanese drug which is still being used very frequently as an add-on therapy for partial seizures. And this drug has only one side effect, that is can lead to certain kinds of kidney stones in 1% people, and people require plenty of water intake to be given when denosumab is used as an add-on therapy for focal seizures. And the last among this group is levetiracetam, the drug which came obviously 32 years before as a drug for anti-anxiety purpose, but now found best uses in clinical practice. I will tell you that when I talk with experts from the institution, they always say, if I have epilepsy myself, we will take this drug. Because this drug is rather much safe in generalized seizures. But remember, even till today, this drug is not approved either as a monotherapy in partial onset seizures. So this drug can be used for first line therapy, add-on therapy for generalized seizures, but not as a first line treatment for partial onset seizures. Then recent drugs, 4 drugs. Last one is outer contention because it is very expensive, not available here. Parampanel has got newer interests recently. The interest is this drug was initially approved for add-on therapy for focal seizures, but just 2 years before, FDA approved this drug as a drug for add-on therapy in generalized seizures also. So parampanel has got very important function. That function is given single dose therapy. Give 1 tablet a day, the drug works. But this is only useful when you use this drug as add-on therapy, not as a drug, as a first-line monotherapy patient. This can lead to serious aggression in some patients. Lacosamide. And this drug has got a lot of good indications at present. And this is the one drug which replaces carbamazepine one day as a first-line treatment for focal seizures. This drug has got basically a sodium channel blocker with a very small 50% protein binding, equally effective like carbamazepine and valproate. It is given 4 to 8 milligrams per kg of weight in a single dose therapy, and it can also be used as an add-on therapy in patients of focal seizures. But of late, it's also been approved as a monotherapy for generalized seizures. So this drug has got 2 major indications. First, monotherapy for focal seizures, monotherapy for generalized seizures. Absolutely safe. So this drug will replace after some time, you just remember, as a first-line treatment for even for ourselves. If you have epilepsy ourselves, we will take lacosamide as a first-line treatment because it is absolutely safer drug as compared to other drugs. Merits of this drug, it's got very few drug interactions. It's got very simple dose titration. It doesn't lead to memory impairment, doesn't cause hyponatremia. It is available also in fluid form, tablet form, injectable form, and can be used also in status epilepticus. There is known to cause sometimes in some cases, suicidal ideation problems, can cause dizziness, ataxia, and certain patients can develop cardiac conduction defects. So therefore, you have to be careful in cardiac patients with this drug and needs to be withdrawn very gradually. Levetiracetam, derivative of levetiracetam. This drug has been approved also by US FDA as add-on therapy for focal seizures, and recently 5 years before, it also approved as an add-on as a first-line treatment monotherapy for partial onset seizures. So this drug obviously, I'd like to tell you that it is a lot of promotional level by all the pharmaceutical companies. They try to motivate doctors to write this drug, but I think better drugs than this will be lacosamide, because that drug has been found to be more efficacious in both generalized and focal epilepsies. This drug is only been approved for partial seizures and not generalized seizures. And next one, cidobamide. Now this drug basically is the latest addition in the new group of newer drugs. It is basically a sodium channel blocker. It has got very few side effects like two treatable may be affected, and patient may have a 1% patient may develop drug reaction, that's the drug syndrome. But this drug is very expensive. It costs 1,000 rupees one tablet. So obviously, I think we can't afford this kind of a treatment in our setup. As we rightly mentioned that we have poor patients. Now obviously, the better drugs are this to give to both the conditions like patients have focal generalized seizure. This is the standard and new epileptic drug trial. What do they say? Now, they have mentioned that remotrigine is associated with a better 12-month remission from seizure disorders as compared to carbamazepine, oscarbamazepine, and topiramate and denosumab. This is a child with basically having chronic seizures, generalized chronic seizures. So this is just to show you that patient may have a focal seizure, patient may have a generalized seizure. So you have a different drugs for both the conditions. The second trial by the same group also had mentioned that lamotrigine and levetiracetam, the first line treatment for women, was more safe, leading to a 27% reduction in the prevalence of malformations from a very high figure. And second thing they mentioned was the valproate was found to be more effective than lev in controlling seizures in a pooled cohort of patients with generalized or unclassified epilepsy. So they both mentioned that a focal seizure drug of choice may be lamotrigine or odomazepine, and generalized seizure drug of choice may be valproate. So this is just the latest last slides of mine, and in fact, just two of them which we have mentioned. They just mentioned about the drug of choice which have to be used. And for our interest, these two are important. For focal seizures, the carbamazepine, lamotrigine, lacosamide, and these four drugs can be used for a first line monotherapy, and we can add the other ones which I mentioned in the right side of the group. And for generalized seizures, still the drug of choice will remain valproate, levetiracetam, lamotrigine, and lacosamide. So in both the groups, even today, the first line of treatment, the first drug of choice still remains the older drugs, the previous drugs, and not the newer drugs, as you can see from here. So, as I mentioned to you earlier, that epilepsy is always challenging. We make a lot of mistakes in diagnosing patients with seizure disorders. Now, this child basically is undergoing EEG test, and you can see that fasting movements which can create a confusion that patient might be having seizure. This can also lead to certain artifact in the EEG also. But this is absolutely a functional patient who doesn't require any treatment for seizure. He requires basically a psychiatric consultation. Thank you very much.
Thank you very much, sir. There are thousands of drugs available. Yes, I'll give you a chance to ask the question. There are thousands of drugs available for a single disease. But good doctor knows which one to be used in which condition. And this is the wisdom Dr. Gandhi has given to all of us with his master in teaching. Thank you very much, sir. Dr. Gandhi, he wants to ask the question.
Thank you. Yes.
That because of the dilutional weight gain fluid retention that you have hyponatremia, or is it just a type?
No, it is a central cause, which leads to sodium deficiency.
You also mentioned that there's fluid retention.
Because weight gain will take time to occur.
Right.
And I just tell you one interesting episode which happened, I think 10 years before. One patient was brought to me, she was taking carbs. And she developed vomitings and certain kinds of features of hyponatremia. She was given IV infusion of hypertonic saline. And after 3 days, she developed unconsciousness. They brought the patient to me. We had the patient. So I referred the case to doctor. They will show there and get it examined. So they got an MRI from doctor. They came back to me. MRI showed central pontine marginosis.
I also had 2 patients.
Okay, with the passing with the IV introduction of hypertonic saline solution. So they could not recognize the patient probably was having hyponatremia and
And giving the
drugs
saline fast,
fast.
and correcting the sodium fast.
Exactly.
These two, and then they landed up with a quadrivalent.
Quadrivalent. So I think that side effect is much less with carbamazepine as compared to carbamazepine. Otherwise, you have lacosamide, you have levetiracetam, with other drugs.
And what is the cost of lacosamide?
It is not much. It is 20 rupees a tablet. So it can be, within 50 rupees a day one can manage. Otherwise, a patient who is poor patient will do well with simply carbamazepine, which costs only 5-6 rupees a day.
So we request Dr. Richa to give us a recording. पहले 4 दवाइयां आती थी, आपने 4 + 4 12 बताती, थोड़ा कंफ्यूजन हो गया. So we would like to read it again.
Yes. Yes, sir.
for 3 year history of seizure for the first time without preceding cardiac etc. MRI and CT reported was meningioma. Seizure was 1 centimeter, 80% slightly irregular. I thought that could it be let me how to distinguish whether it was meningioma or let me small blood and we are with anti-epileptic drugs. The father of the patient told me that maybe seizure free now since then. So how do you distinguish between meningioma and small blood clot? And
It's a different subject altogether because the question is different. You see, this is a report by the MRI, by the radiologist. Basically, you will tell that the patient has a meningioma, but you will find a stalk. There is a stalk in the meningioma, the tumor, which can be attached to the parts or the meninges, right? And the bleed will be parenchymal. It can't be peripherally placed near the vault. That's one way of differentiating it, because they both look hypertense on the CT scan. So you have to differentiate the meningioma from the bleed cell. Yeah, they are hypertense. Both are hypertense. Blood is also hypertense in the CT scan. So the meningioma is hypertense in the CT scan. Another thing is very important to remember. I tell you one case when I was fresh in this college when I came. I had a patient who was having seizures. I mean, some kind of movement disorders. I was just fresh. I believe within a 6 months time, the patient came to me when I was in Canada as a lecturer. And so I diagnosed the case to be a functional patient. It's a functional seizures. Right-sided functional seizures. So I referred the case to my teacher, Dr. Devika Nath. I said, Madam, actually, this patient and finally, she got a CT scan done. That showed a meningioma, small meningioma, small meningioma. And I got a finding from her that this patient had meningioma and he was saying it is a functional patient. So patient came back to me with a letter. And I was so ashamed to see that I made a wrong diagnosis. Then I again saw the patient scan and clinically examined. Again, he had the symptom moment in front of me. The meningioma was situated on the right side, smallish. And the patient also had the right-sided focal movements, which can't be obviously because of the meningioma. So then I had a relief. I wrote to Madam again, Madam, I saw this patient once again. It's got a same-sided meningioma with the person having the focal seizures. So it is again a case to be a patient of psychogenic or pseudo-seizure. That's how. So important point is also there. That finding of the scan, is it really causing that particular movement or not? How big is it? How big it is? How important it is? Whether it's correlating with the site of the seizure or not, and things like that. So basically, you require correlation of the investigations and the correlation with the history which you take with the patient. What you see in front of you is something different. What the scan shows maybe something different. To correlate both the things together. You may have a normal scan in a seizure patient. You may have a finding in the scan without this. I think I am able to explain to you, sir, what is the question you asked. Yes, sir.
And as we know what computer heart block, and since history is already shown in the initial sites, history is very important. But these patients are on anti-epileptic most of the time because the history sometimes not taken properly or not available because patient has been alone. Sometimes you don't know the duration of the unconscious. Most of the patients they starts anti-epileptic drug, but finally they are diagnosed as a complete heart block or sinus down.
Stroke items, stroke items.
Very common.
It is not uncommon.
Yes.
Not uncommon. Yes, not uncommon. So we have to see patient's pulse, always pulse is very important.
Yes.
thank you for the excellent presentation. I think we learned a lot from the older and integrated us to your thank you, sir, very much.
डॉक्टर नवनीत को अभी जब ऑनर किया जाएगा तब दिया जाएगा. नाउ आई रिक्वेस्ट चेयरपर्सन टू खाली कर दें सीट. बहुत देर हो गई बैठे हुए. You wanted to say something. Dr. PC Singh wants to say something about Professor Rams.
Dear friends, I think I'm the oldest person to have worked in the unit of Professor Ramsey. I was his house physician in 1967, his resident in 1968 and 69. And I learned that what discipline is from him. His OPD days were on Fridays. And on every Saturday at 8 a.m., Professor Ram Singh stood in the ward with a long apron and a tie, and with, you remember, his specs. And we, being in the unit, were forced from the evening of Friday to the morning 8 a.m. of Saturday to prepare our notes. Physicians' remarks, residents' remarks, with investigations of stool, urine, and whatever the blood investigation other than biochemistry to be done in the ward. So whole night we used to work, and we used to be there in the ward to see Professor Ram, waiting for him exact at 8 a.m. So I want to pay my tribute because sometime back he passed away. I feel it's my duty and all the persons who have worked with him and worked in his unit to pay a tribute to him because he taught us discipline. Thank you very much, friends.
Now we come to the felicitation part of today's program, and that is our teachers will be there on the dais, and I will invite those who have to garland them and hand over a memento to them. First of all, I like to invite Professor Santosh Kumar sir to come on the dais. डॉक्टर बीडी अग्रवाल सर, मुझे याद है वो दिन जब पहले दिन मैं थर्ड ईयर में आया था, ओपीडी में पीछे 7 नंबर कमरा था, वो ओपीडी वाला जो मेडिसिन का था, उसमें सवाल पूछा था, टेल मी 101 कॉजेज ऑफ फीवर. 101 कॉजेज ऑफ फीवर. बहुत डर लगता है आज भी फीवर जब देख लेते हैं. 101 causes of fever on day 1 of third year is very difficult. Very easy. Most difficult question is what is the component of the fever? It is most important. That is the most difficult question. Then next is Dr. Rakesh Chandra sir to come on the dais. I have a privilege for inviting my batchmate, Dr. Aarti Lal Sultani, to come on the dais, and Dr. Navneet Kumar sir to come on the dais. And then I invite one by one the people, the doctors who are present here, and they will garland and hand over a memento to our respected teachers. First and foremost, I'd like to invite Dr. Amit Gupta from Lucknow, Dr. Richa Giri, Dr. D.P. Agarwal, and Dr. A.C. Gupta to honor and felicitate Santosh Kumar sir. He has been my guide during my PG thesis. Very strict person. वैसे ही कड़क आज भी दिखते हैं. आप देख लीजिए, एक भी बाल सफेद नहीं मिलेगा और वैसे ही टिच लगेंगे आप. कई बार थीसिस की वो लिखवाया, उस समय टाइप करनी पड़ती थी, कंप्यूटर नहीं था, लिख के और हमेशा कहते थे कि इसको दोबारा लिख के लाओ। फिर वही चीज, वो द्विवेदी जी थे, वो उसमें जो टाइप करते थे, डॉक्टर त्रिवेदी हंस रहे हैं कि वो कहते थे फिर यही दोबारा वाली जो कल जो टाइप करके दी थी वही ले जाओ। That is what, yes. जैसे अग्रवाल का हटा दिया, वो भी नहीं है मेरे ख्याल, के शर्मा भी नहीं, के शर्मा इज नॉट, कमल कांति शर्मा भी बैठी थी अभी चली गई। उनको रफीक को भी to honor Dr. B.D. Agarwal sir, I like to invite. He's still very energetic. Dr. B.D. Agarwal. वो जो कहते हैं ना hypocaloric जो बता रहे हैं ना, उसी का असर. So Dr. A.K. Trivedi, Dr. Saurabh Agarwal, Dr. J.S. Kushwaha. Yes. And Mishra to honor most कड़क teacher of Viva, जिनसे बहुत डर लगता है.
हमारे जेम्स राज में the most popular teacher was there because he had a voting and he got all the votes, the most popular.
Yes, as a teacher, he used to be very popular. He is still very popular. We pray for long, healthy life of Dr. B.D. Agarwal.
It used to be fun. Yeah, very witty teacher, very witty.
Well said, Nandini. It varies with time. It used to be COVID. It used to be COVID last year. Yes, it varies.
मुझे सबसे अच्छा कमेंट लगा. This patient can die due to 100 causes. This patient can die due to 100 causes. But you should not be one of them.
Dr. Santosh Kumar sir, you will like to say something?
मुझे इस हॉस्पिटल और मेडिकल में बहुत कुछ मिला, बहुत कुछ. मैं अभी भी जितना अर्न कर रहा हूँ मेडिकल कॉलेज हॉस्पिटल हॉल में हम लोग बैठते थे, मैं उसी से फल मिल रहा हूँ. आज भी 30 इयर्स का मुझे मेडिकल कॉलेज में बहुत मिला. मैं टीचर कहते हैं आप लोग हुए, लेकिन मैंने बहुत कुछ सीखा स्टूडेंट से. टीचर के डॉक्टर का सबसे बड़ा टीचर टीम है. नंबर 1 पेशेंट्स को देखकर ही बुक लिखी जाती है. नंबर 2 मेडिकल कॉलेज में 30 केसेस हमको बताए जाते थे पैथोलॉजी में, 2 पेशेंट बेचारे मर गए थे, माइट्रल स्टेनोसिस से मरे थे, हार्ट फेलियर से मरे थे, लिवर इन लोगों को देख कर भी पहुंचा के हम लोग। मैं आपसे बस यही कहना चाहता हूँ, डॉक्टर के पास पेशेंट जाता है, बहुत सारे डॉक्टर कहते हैं आप डॉक्टर है कि मैं डॉक्टर, ठीक है चुप रहो, मैं डॉक्टर। एक डॉक्टर डॉक्टर का सबसे बड़ा जितना वो पढ़ाता है, वो पढ़ाता है, हर मरीज मेरा डॉक्टर, हर मरीज वो हमको सिखाता है कि जो दवा आपने दी उसके क्या क्या साइड इफेक्ट हुए, आपने क्या करना चाहते उनसे हम देखते हैं पेशेंट हाथ धोता है, पैसा नहीं देता है, हम सीखते हैं उनसे कि इंडिया में कितनी गरीबी है, कितने गरीब पेशेंट, हम उनसे सीखते हैं कितनी गरीबी है, कितने अनपढ़ हैं इस इंडिया में, कितने लोग अनपढ़, कितने गरीब हैं, पैसा नहीं दे सकते हैं। और एक चीज मैं आपको और बता दूं, अगर आपके पास टाइम आप कृपया, हम सभी लोग मैं अपने से भी कह रहा हूँ, अपने हर मरीज को आप ऐसे दीजिए जैसे आपका मेरा हो। अगर आपने यह सीख लिया, अगर आपने सीख लिया तो सारे कंज्यूमर कोर्ट डॉक्टर के अंदर जितने भी केसेस हो रहे हैं, कभी डॉक्टर को नहीं करना पड़ेगा, वकील बैठे रहेंगे, वो आपके सामने केस नहीं ला सकते, जज बैठे रहेंगे और अगर आज हमने ये सीख लिया कि हमारा प्रत्येक चाहे वो 80 साल या हो कोई भी हो, वो हमारा पुत्र है, हम लोग क्या नहीं करते, हम चाहते हैं हमारा पुत्र हमारे सामने बीमार है तो हमारे सामने इलाज हो, अच्छे से अच्छे डॉक्टर के पास हम जाएं। मेरा MBBS का लड़का को बीमार पड़ा तब वो आपने कहा हमने समझा नहीं बचेगा, हम सबको याद कर रहे थे, हम सोच रहे थे कोई अच्छा डॉक्टर हो तो हम उसके पास पहुंच के जाएं, हम रो रहे थे, मैं नहीं बोल रहा था मेरी बात को हम करें। तो यही साइकोलॉजी हर पेशेंट की होती है, वो बोलता नहीं है, वो कहता नहीं है, वो आगे में बैठा रहता है, उसका 4 साल का बच्चा बच्चा बाहर खड़ा है, उसकी वाइफ घूंघट खोल के और बैठी हुई है, हम ये सब देखें आना है, ये साइकोलॉजी होनी चाहिए। दूसरी बात मैं आपको ये और बता दूं, मस्ट अटेंड दी पेशेंट इन नीड, इन डेड वी मस्ट अटेंड इफ द पेशेंट हैज बीन डॉक्टर हैज बीन कॉल्ड बाय द पेशेंट। हमारे टीचर के डॉक्टर सागरा में बड़े रेस्पेक्ट करते थे, जो मेडिसिन मैंने सीखी है आगरा मेडिकल कॉलेज उन्हीं से सीखी है, ट्रांसफर हो गया, मेरा गया था नर्सिंग होम में, रात को 12 बजे अटेंडेंट आई, बड़ा उन्होंने भाई से कहवा दिया डॉक्टर साहब नहीं को पता चल गया कि डॉक्टर साहब, उन्होंने FIR दर्ज करा दी, मेरा बेस्ट टीचर है अरेस्ट, इसलिए अटेंड करो जब भी बुलाएं। एक बात और मैं बता दूं जो हम नहीं समझ पाते, पेशेंट का हर वर्ग गोल्डन वर्ग समझना, सुनाओ सीटी दिखाओ, MRI दिखाओ, अल्ट्रासाउंड दिखाओ, हम सब देख लेंगे, आप चुप रहिए, आपको कैमरा बताएंगे, विदाउट हिस्ट्री वी आर डॉक्टर का ब्लाइंड, चाहे जितने CT स्कैन हो जाए, MRI हो जाए, अल्ट्रासाउंड हो जाए, जब तक आप उसके बात नहीं करेंगे तब तक सुनेंगे नहीं, कुछ नहीं होगा। डॉक्टर ने कहा एंडोस्कोपी करा दो, 8 साल का बच्चा है, बोन की हो रही है, एंडोस्कोपी करा दीजिए डॉक्टर साहब। मैंने कहा देखा उसको, एंडोस्कोपी की कोई जरूरत नहीं है। अरे आप में कहा है एंडोस्कोपी कराओ, मैं आपके पास आ गया ही तो मैंने कहा कि इसको हिस्ट्री दी, तो हिस्ट्री के पीछे क्या था? लखनऊ में नौकरी करती थी, 8 साल के बाद रहता था, इसलिए मैंने क्या है तो रहता हूँ, होता है वो होगा, हो गया बड़ी से बात जरूर करिए। यहाँ पर कभी कभी मरीजों को रेफर करता हूँ, कभी कभी मरीजों को रेफर करता हूँ, तो मेरे पास डॉक्टर ने क्या बताया, अरे साहब उन्होंने कुछ बताया नहीं। तो मैंने कहा उनको बुला के उन्होंने अटेंडेंट को बुला के उन्होंने पूछा, अरे साहब किसने पूछा, तो आपस में डॉक्टर को उधर करते रहे और जो उनके डॉक्टर थे उनसे बात करते रहे, हमसे पूछा ही नहीं। हम सीखते हैं धीरे धीरे, इसकी साइकोलॉजी समझने में डॉक्टर को 100 साल लग जाते हैं, हम उसकी साइकोलॉजी नहीं समझ पाते कि क्या चाहता है हमसे क्या चाहता है, ये सारी चीजें हैं। तो आप इसको ध्यान रखिए, अगेन करिए और गरीब से गरीब मरीज को देखिए, अगर कुछ बीच में कमी हो सके तो करिए।
Next is Dr. Rakesh Chandra, and I will invite Dr. A.K. Tripathi from Lucknow, Dr. Saurabh Agarwal, Dr. J.S. Kushwaha, Dr. A.K. Tripathi, Dr. V.P. Predarshi, Dr. S.K. Gautam, and Dr. V.K. Srivastava. Please come in honor. ये डॉक्टर राकेश चंद्रा साहब के बारे में एक बात बताना चाहूंगा कि ये बात करते थे तो एक गाली देते थे, डॉट 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 लगाऊंगा, मैं बाइक से बोलूंगा नहीं, आप सब समझ गए होंगे। एंड ही स्टिल सेम विटी, सेम टू द पॉइंट। मैं नहीं, मेरी जरूरत नहीं है वो गाली देने की। तकिया कलाम सर, दो मिनट ही देंगे सर, थोड़ा कुछ कह दीजिए, गाली छोड़ के दो। हाँ, next in the list is Dr. Aarti Lalchandani. I like to invite Dr. Nandini Rastogi, Dr. Mohammad Rafiq, जिनसे पूरा हिस्ट्री टेकिंग मैंने सीखा, जो 3 साल में डॉक्टर सिक्का 4 पेज की हिस्ट्री लगवाते थे, वो 4 पेज की इन्हीं से सीखा। डॉक्टर विशाल गुप्ता एंड डॉक्टर समीर गोविल। वो लंबाई देखी जाती थी, उसी पे एमडी अवार्ड होती थी। इतना लंबा, एक के नीचे एक पेपर चिपकाया जाता था। सारे ऑप्थेल्मोस्कोप से लेके ईयर तक देखने का अंदर जो है वो सारा पैराफर्नेलिया इनके हाथ में रहता है। यस, डॉक्टर आरती, यू वांट टू से समथिंग? 2 मिनट देंगे सर। नहीं बट मैं ले सकता हूँ बिकॉज शी इज माई बैचमेट।
The best was that मेरे thesis topic जो थी वो पेश लेकर थी detect latent coronary artery disease in diabetic patients. तो latent coronary artery disease detect करने के लिए ऐसे आरटी चैनल को कभी टाइम निकालना होगा, टाइम वो था ना पेपर से। So, but I was very happy. क्योंकि मुझे पता था कि अपने डॉक्टर आनंद टंडन, डॉक्टर के सिस्टर ने बीसीसी, डॉक्टर आनंद टंडन ने पेश में कराया तो मैं तो वहां से और 20 केसेस करने के हमारे पहले डॉक्टर रफीक किए हुए थे पेश में करवाने के। इन्होंने 50 केसेस को बैड साइड देखने का लीड डाला। तो मैंने सोचा डॉक्टर रफीक कराई है, डॉक्टर टंडन बोले डॉक्टर रफीक करा देंगे, उनको पेश में कर देगा। उन्होंने एक केस कराया। एक्नॉलेजमेंट दी रेजिडेंट ने अपने वो सीनियर वाले जिससे उसकी वाइफ
थैंक यू आरती। एक स्टोरी
एक हमारे साथ हमारे सीनियर पोस्टेड थे डॉक्टर गहलोत। तो डॉक्टर गहलोत की राउंड पे आते थे, हम लोग क्या करते थे बाकी कंसल्ट में एक साइड राउंड में फिर मुड़के और दूसरी साइड राइट और लेफ्ट ऐसे ऐसे राउंड लेते थे। तो हमारे साथ एक सीनियर थे सरदार। तो पता किया समाज में किया उन्होंने, लेकिन हम जॉब से हमारे किया नाम नहीं बताएंगे यहीं पे है उसमें निर्देश था और आईटी और पेज का इसमें गोली से करने में तो
राउंड पे गोली फीट कर।
तो डॉक्टर गहलोत ने बोला कि इसका सीएसएफ रिपोर्ट क्या है, उन्होंने सीएसएफ कराया ही नहीं था। तो
बायोकेमिस्ट्री एंड माइक्रो
तो उसमें सीएसएफ में शुगर कितना भूल गया। तो डॉक्टर गहलोत ने देखा ये तो पास पूछा करता था करा रहे थे तो बड़े पूछा करता थे। तो मैं अच्छा शुगर की रिपोर्ट नहीं डॉक्टर गहलोत ने वेरी फाइन। तो उन्होंने कहा शुगर तो घर से बोले पीएच खत्म हो जाता सर। तो डॉक्टर गहलोत बोले राउंड के बाद आके वो पूछा करता था समय के बाद सीएसएफ का ये शुगर का है कि और वाकई निकले वहां से और गए और मुझे शुगर का ये का खत्म क्या बोले नहीं तो क्या मैं रिपोर्टिंग कर रहा है। तो उन्होंने कहा ये तो सताती चार दिन तक नहीं आ। एक और कहानी बताए
बात कर रहे हैं टीचर्स के पास में अगर माइक आ जाए तो ये बड़ी बहुत मुसीबत है।
कभी नहीं आता तो उसके पता लगा और जो हमारे सीनियर थे उसने हमें हमारे सीनियर थे अभी नहीं तो गारंटी के और जब राउंड पे निकले उसको बोला ने कि इस पेशेंट को अच्छा 2 ब्लड लगा दो। उनको कुछ नहीं पता था ब्लड लगा दो पता सीनियर हमें डॉक्टर से ब्लड लगाना नहीं सकता तो इन्हें नो ब्लड लगा तो उन्होंने कहा ब्लड लगा बोले ग्लूकोज के साथ लगा दो। बोले अच्छा ग्लूकोज के साथ उन्होंने ब्लड मंगाया एक ग्लूकोज का डब्बा
I remember that. I remember. ये जो किस्सा था ये हम लोगों के बैच में बहुत पॉपुलर हुआ था। And next to be honored is Professor Navneet Kumar, and I'd like to invite Dr. D.K. Sinha, Dr. Ved Nigam, Dr. R.K. Verma, and Dr. N.P. Singh. And we'll have a group photograph of all the teachers. Rakesh Chandra sir, चले गए? Hemoglobin कराने तो नहीं गए? And there will be a final group photograph with all the teachers who are present here. And we like to invite all the speakers, Dr. Amit Gupta. Yes, sir, आप ही का माइक है, बस एक ही मिनट बोलिए. ये.
The hospital like this, project is he डिपार्टमेंट ऑफ मेडिसिन में न्यूरोलॉजी जब मैं आया यहाँ पे करने के लिए तो काफी लड़की जो थे एक्सपायर हो गई और मुझे कहते हुए काफी फख्र है कि इस डिपार्टमेंट से 42 रेजिडेंट्स इस समय कंट्री के अंदर न्यूरोलॉजिस्ट जिसमें कम से कम 6 गर्ल्स भी हैं दे हैव डन न्यूरोलॉजी और एक टाइम ऐसा था जिस समय की एचओडी ऑफ एम्स न्यू दिल्ली की जो हेड थी डॉक्टर माधुरी बिहारी शी हैड सेड उन्होंने ये कहा कि जीएसपी मेडिकल कॉलेज इस समय न्यूरोलॉजिस्ट प्रोड्यूसिंग फैक्ट्री बना हुआ है there are so many boys going from here to become neurologists. That's great. Thank you.
Now, I like to invite Dr. Gautam to words, maybe vote of thanks. डॉक्टर रिचा से ये रिक्वेस्ट करेंगे कि अगले साल भी 51 साल ही चाहे हो एक ऐसी मीट रखिए जिसमें एकेडमिक्स ना हो सिर्फ पुरानी जो यादें हैं वो ताजा है. डॉक्टर गौतम.
Thank you, sir. And thank you everyone for being here. It's my proud again to say a vote of thanks to all my teachers here present. सर ने कहा अभी कि हम हेलट से ही रोजी रोटी खाते थे तो सर की बात सही है. आज हम लोग भी जो फल फूल रहे हैं वो सर आपकी टीचिंग की वजह से ही फल फूल रहे हैं. यहाँ पे हमारे टीचर्स ने जो हमें प्यार दिया, जो हमें सिखाया, आज हम उसको अपने क्लिनिकल प्रैक्टिस में लाकर उसको कर रहे हैं और इसकी वजह से ही ये आगे बढ़ रहा है. अगेन आई थैंक्स आवर टीचर फॉर बीइंग हियर एंड blessed us and simultaneously I like to thank the all alumni who came all over the country to attend this program and make this program a mega success. I hats off to you. I sincere thanks to all of you and sincere thanks to our organizing committee members, our residents of the department, and everyone, media persons. I'd like to thank the media persons also. I'd like to thank our department's staff also. So it's a composite efforts to make this event successful. Thank you so much, everyone. Thank you. Jai GSP.
Okay, before we
बस ये तो होना ही है. 3 cheers for Dr. Richa and her team. Repeat. For the residents sitting in the back, आज repeat पूरे हो गया, आगे मत करना. Thank you. There is a group photograph of the organizing committee, so please kindly come on the stage.
Organizing committee member, please come on the stage for the group photographs. Saurabh sir, Shwa sir, ma'am, जो भी आंसर हो जाएगा ये. अब sir, I request all the organizing committee member to be on the stage. Bijmohan sir, Nandini ma'am, Vishal, Dr. Vishal, Dr. Aake, Dr. Mahen, Dr. Lalit. आइए. आ जाओ विशाल. Piyush, Dr. Piyush, Dr. Samir, Dr. Saurabh. It's all hard work of our team to make this event successful. I request our residents of the department to come and have a photograph with this organizing committee members.
Start.